Sir.
Thank you, sir. Good evening to all. I welcome everyone to the IAOHNS webinar series 7. So indeed, it's my pleasure to welcome you eminent faculty and guests to this very interesting academic session. Under IAOHNS, we are planning to have a couple of head and neck sessions. So this one to start with on thyroid management, and next it's going to be on salivary gland management. So these two are going to be totally on head and neck, complete head and neck faculty, and including ENT faculty. So today we'll be dealing with management of thyroid disorders, and our moderator for today. It's my pleasure to introduce Professor Madan Kapre sir, who's a senior ENT and head and neck surgeon. And yeah, he requires no introduction at all from us. He has conducted various thyroid workshops and conferences all over the world. And he's the director of Neeti Clinic, Nagpur, and he's got the Lifetime Achievement Award from the FHNO. And he's got the Lifetime Achievement Awardee, Academy of Otolaryngologists of India. And he's the National President, Foundation of Head and Neck Oncology, and founding National President, Thyroid Surgeons of India. National President of Voice and Laryngology Association of India. I request him to give the first session talk, and he'll also moderate the session from there on. Sir, can you please start the first session? Thank you.
Let me formally welcome all the faculties who are going to participate later on. I also want to thank Professor Mohan Kameshwar, Professor Vijay Krishnan, Sarath, my friend, and everybody at MURF and everybody at the Academy. Also, the Professor K.K. Handa, who is the President of the Academy, who has very graciously accepted to have a thyroid session. And I'm sure that we do justice from our side. I have a difficult task in as much as we are the best of the best in the world on thyroid and also from the country. At the same time, we got to pitch it to a person who are like the average operating surgeon. And also we want to pitch it to the learners and don't want to shoo them away or scare them away by saying it's too difficult, leave it. So I'm in a position where I have got this particular job at my hand and I will try to do as best as I can. But before we begin, I want to share for first 15 minutes or so the wisdom that I gathered from the foothills of Chikaldara. Now, when the name comes Chikaldara, it is like a Gurukul. So 3 days on, all the participant delegates practically live 24 hours together. They have their food, they have their dinner, and for their food and the dinner, the menu is thyroid. So from morning till night, they eat and drink thyroid. Now, where is this Chikaldara? The Chikaldara place is about 150 kilometers from the nearest of the township and about 250 kilometers from Nagpur. It is the southernmost part of the hills of Satpura ranges, and the people live in a small hamlets of maybe 50 or 100 and scattered over a period of a location of around 60 kilometers. And what you see over there is the rural hospital of Chikaldara, where this camp is held every year. It doesn't look so desolate when we get there because there's a lot of hustle bustle. We put some marquees, pendals as we call them in India, and accommodate the people who are coming. The structure of the camp is very simple. For the first 3 days, we have people doing general surgical procedures. Few of you know probably that I also am from a general surgical background, and we do a lot of general surgery. And the aim is to deliver the patients the service that they need and send them back to their home. So that's the motto of this camp, is to free them of their ailment as best as you can. Chikaldara goiter. You can see them on your screen. That this is what we nickname them as the Chikaldara goiters. Now, why do they let them grow so big? Is it because of lack of medical services? Is it because of lack of faith of them into the modern medicine or the doctors? But sometimes you ask a question, and my next slide is going to be the slide that will make you think even in your practice in a place which is urban like Nagpur. Think, this lady over there who has got such a huge thyroid, which has been there slowly growing for last 12 years, She has no compressive symptoms, she has no problem eating, no problem breathing, no change in voice, and definitely she is not going to worry about the cosmetic. And have a guess, why has she come to me? And I asked that question myself, and I will give you the answer. She cannot carry the wood from the jungle on her head for the evening fire for cooking at home. Look at this. That's how they bring the wood from the jungle. Now, what she has got, please look carefully above her ear. She has got a big metastatic disease in her skull, and she cannot take that weight on her head. And that brings her into our clinic asking, can we do something? But the wisdom that I got from there is to ask even my Nagpur patient a question, why are you here? Now the answers are different. Just to share, the lady in the middle has got a cosmetic issue. The lady in the yellow has got an issue of the nodule, which she has gone on the net and found out can be a cancer. The lady on the left, which is almost like a Chikhallara goiter, was scared of surgery, and the reason she come now is because her next door neighbor had his thyroid, which was done. He's sound and safe, so she got the courage to come to the clinic. So you see, you learn from the patients, and that's the wisdom coming off from Chikaldara. But before we head off to getting more wisdom from the operating room, I would like to share with you this picture. Now, this picture is the people on whose shoulder the Chikaldara camp stands so tall. On the front left, you are seeing Dr. Deven Maure, and the right see Paul Konovich. In the middle somewhere, you see the godman of thyroid. That's Greg Randall. Now, would you ask me, why did I put these two pictures? What does resemblance? The reason is that no matter how, as much is the sad part of it though, that the recognition came to us in a big way only after the Greg Randall and his team visited us. And that's the part I must admit that suddenly we were on the international scene. And until then, for 24 years, doing the same job, nobody took a notice of us. That's not a complaint, but that's the point. But let's see what Paul Konovich has to say when he was returning back. This is what he said. To sensitize the haves to the sufferings and yet astonishing happiness of the have-nots. He saw a little boy running after our jeep, like a safari jeep, and carrying a half cooked or half eaten kind of a bun, what you call them, a bread or a biscuit, and waving us goodbye. And he said, what makes him happy? There's no future as far as I can see it. And I said, Paul, I've been coming here for almost 25 years. I do not know the answer. But anybody wants to know the answer, you are welcome and try. Clinical sense has to prevail all the time. And that's what prevails there because we don't have much facilities except ultrasound, which is pretty elementary, FNSE, which Professor Maure's wife does, and TSH and T3, T4, which my good friends in Amaravati, which is about 150 kilometers from there. So we need to send the samples and we get the reports the following day. So this all happens about few days prior to the thyroid camp when the general surgical work is going on. But all the time, what haunts you really is this picture at the bottom. That who are the type of patients we are dealing with? They are so happy for the food they are getting, the way they are getting. And that's always haunts you before you make any surgical decision, or shall I say, you are scared to make a surgical decision. And this is no brainer. I mean, if you ask me what the optimum surgery these people will undergo, without a doubt, this is a total thyroidectomy. We won't waste much time on here. But then there are lessons we have learned from the various things, and let's take assessment of airway. And what confidence I have gathered working there with this patient is, if the patient is not dyspneic at rest, if the patient has no change in voice or difficulty in swallowing, 9 out of 10 times without any difficulty, you probably can get a nasoendotracheal tube very safely without a bother. Because very rarely the tumor will compress the airway in such a fashion that you are unable to intubate because the flexible tube will make way for itself. The next lesson we have learned from there is a myth about tracheomalacia. People keep on talking. I have seen and I've done the thyroid the way you saw in the picture, but for last 25 years we have never ever I mean, I will say, never should say that, but we don't have a patient who really had a bad thing with tracheomalacia. Now, lessons learned from large goiters love the anesthetist. Don't say that because my wife is an anesthetist, but I say that because unless you are in tune with the anesthesia and in tune with the thinking and the treatment, you cannot get on with it for a long time. And that's exactly the truth with the thyroid surgery. That unless you are in sync with them, and in particularly a situation like that, always share. Because once upon a time, there was a picture of a trachea deviated to one side, and somebody said laughingly, don't show this x-ray to the anesthetist. I would say quite to the contrary, show them and reassure them that I can pull the thyroid to the opposite side and bring the trachea in the middle, because most of these things are unilateral and the intubation is not a problem. Importance of exposure. I can't stress this enough. You see, the key surgery for this large thyroid we learned is exposure. And look at the way the muscles are stretched. They almost look like fascia. But once you release them, the job is easy. Don't shy away from cutting. There is no problem in cutting the muscle and getting the muscles back sutured up. But just take care that you don't damage their nerve supply. And you learn this next basic is at various levels, and the higher you cut, the better. The textbook says 2/3, 1/3. I would say go as high as you can get a stump of the muscle, which will allow you to suture back. The next thing is the midline. It's a very easy said than done. Because these large tumors, they push them to one side so much that the midline is almost missing or difficult to get. And the thing which is the platysma is deficient in the midline. So you can go by the rule of thumb that wherever there is no platysma is a midline. The second, of course, the two anterior jugular veins, and the rest of the things are in the textbook, which is the notch and the suprasternal notch and the tracheal cartilage notch and all that. I will not go into that because that is standard practice all over the world. Now, handling vessels. Look at these scary vessels. I mean, we are not yet gone on to the thyroid. And this is just anterior jugular bunch of vessels. Now, once they become so big, what lessons we have learned is don't be just admiring them that wonderful. Now we are going to have a good time and smile at each other, but think why they are so big. Because probably there is something in the mediastinum, something obstructing the outflow of these vessels which are making them so big. So once you see them, be aware it may be a dumbbell-shaped pathology where some of it may be dipping into the mediastinum. Now, those big vessels are the ones which you worry about, and the lesson you learn, don't make them bleed, and that's the first thing you do. And wet mops and more mops. No cautery will help you, throw them away. What works there is a transfixation sutures, because these vessels are devoid of the muscle coat and they don't shrink or contract, but they keep on oozing like the nasopharyngeal angiofibroma vessel. And the thing you do is transfix them. That's the thing from there. But more importantly, look at the stumpy, small middle thyroid vein. We had a disaster there once because one of the arrogant or brave or bravado surgeons said, oh, just put a finger around it and put them back. The thing delivers itself and tear into the middle jugular. And the middle vein will drain or tear will continue to go into the jugular and you could be in terrible mess. So never ever do any finger mobilization, no matter how tempting it is, to avoid the damage and retraction of this middle thyroid vein and going into the jugular area and then not getting it. Avoid cautery all the time, that's I keep on saying all the time, is because the vessels, when they cross over in a little way, and there is always a vein which is called as the recurrent laryngeal vein, or I thought one of the talks when Dr. Shaha said that call them the Shaha's vein, because that is a notorious one which will dip into the larynx and then try to catch it and you will cauterize the recurrent nerve. So that's a big lesson we learned, that no cautery in this area. Learn to do suturing and learn to do very delicate suturing so that you do not cauterize accidentally anything which you don't want to. Now, preservation of parathyroid. This is no discovering the wheel or reinventing the wheel, as I said. Everybody talks about it. I mean, William Harsted made an observation about the surgical techniques of Theodore Cocker and Bilrock, and said one surgeon had the codal thyroid missing, so the patient had stumipriva or they had hypothyroidism, where the other surgeon who went more dashingly and more cavalrous approach, and they land up with tetany and not thyroid, because thyroid was left behind and parathyroids probably were knocked out. The lesson I learned was from this lady, and I call her as my tutor in chief. And why I call that? Because she survived the surgery in epidural anesthesia, and I had a big applaud from the auditorium because she had, you can see, the thyroid from one mastoid to the other. But I lost her after 11 months. And I lost her because she became hypoparathyroid. I damaged the parathyroids. And no matter how much I convinced her on taking the tablets for calcium, she won't take it. She repeatedly came back in tetany, and ultimately we lost her. That was almost a backsetter for us, and we were quite in shock for a while, and then went to the drawing board. Jyoti, can you see yourself there? This is one of the pictures where we did 14 cadaver dissection sessions in a row before I went back to Chikaldara. And I discovered something, a lesson we learned, and I confirmed that with Professor Manu Kothari, late Professor Manu Kothari. We lost her recently, and he told me about the organelle supply of the body. He said, God doesn't make a bad design. For all important structures, he supplies them dearly. And I will show you what that organelle supply is in my next few slides. But when we did the dissection, we discovered something interesting. That's the recurrent laryngeal nerve. That is the inferior thyroid artery. That's a branch which climbs before even the fork appears and goes to the superior parathyroid, which you can see in the picture so clearly. And then you also see another branch which can go under the recurrent laryngeal nerve and then go into supply the inferior parathyroid. So the lesson we learned that no matter how the earlier days teacher taught about ligating of the inferior thyroid artery, we do not anymore recommend of ligation of inferior thyroid artery. We say stay put on the gland and only clip those vessels which are actually entering the gland. And now, from the lessons learned in the anatomy hall, look at this picture. Here you see the anterior branch of the superior thyroid artery, you see the posterior branch of the superior thyroid artery, and then you see one more branch coming across and joining with its fellow from the inferior thyroid, and that's the vascular loop which we described will supply the parathyroid. As long as you are anterior or ventral or superficial to this loop, you are safe and sound. Next, don't leave the gland, but leave them in their natural colors. I said true colors of Benetton. That's a very catchy phrase younger people like to hear. Don't just leave them, but they must be nice and yellow, not crimple, not crimson, not violet, and never mind, black is far from the consideration. So you must leave your parathyroids as they look when you saw them for the first time. Now, the variations in vasculature. Look at this inferior thyroid artery. See the way it's climbing. And as it is climbing from behind the recurrent laryngeal nerve, it's giving away a small twigs anteriorly and supplying into the thyroid. But look at where I put them into clip, where that's a terminal branch before it goes away and supplies the superior parathyroid. So if you save this, you have saved the day for you and your patient. Now this is the organelle blood supply. The recurrent laryngeal nerve, and you can see the superior parathyroids, you can see the inferior parathyroids, you can see there is a loop and a small little twig going after the anastomosis into the thyroid. Now that calls for a re-christening, and I said, with this much lessons I learned on cadaver dissections, which translated later on into the Chikaldara, that we need to really reconsider whether it should at all be called as an inferior thyroid artery, or should we be talking to call it as a parathyroid artery. Now, this is one more lesson we learned, is about ligation of the inferior thyroid veins. As much as we have learned to ligate the arteries bang on the thyroid, we must also ligate the veins bang on the thyroid. Because if you bang them, ligate them away, you will create a wet gangrene of the parathyroid because you will be devoid of the return of the vessels, and therefore they will die of congestion. Now, the last lesson which everybody talks about is recurrent nerve. But as you grow in the years, you know unless you are a ham-fisted surgeon, recurrent nerve is not an issue. Issue was what we talked about earlier is parathyroid. Look at that picture one more time. That again, the recurrent nerve is dividing, and Lord behold, see the second picture in the OR. The recurrent nerve is actually multiply dividing, and we believe that recurrent nerve in almost 1/3 to more percentage of the patients divides. And again, this slide show with a little bit of a punch that this can happen only in Chikaldara. That in one consecutive camp, we got a person who had a non-recurrent recurrent, and on the same day, we got another table where operating was going on, where the patient with the dextrocardia actually had a non-recurrent on the left-hand side, which is the rarest of the rare variation of the recurrent nerve. Now, look at these two pictures. The picture on the left, where you can see the recurrent nerve climbing up, you can see the carotid artery. This is what I did before. But now I believe that respecting the God's drapery and leaving the fascia on, the second picture which you see on the right-hand side is far better picture for you and the patient than demonstrating something like that in the OR and getting a loud of applause from everywhere, but not so really if the patient is then deprived of the parathyroids. Now, one thing I will urge that people who are not so privileged to work in big institution and have a privilege of having a nice cautery where it is precisely working, please avoid cautery at all costs. Reason being, I mean, I know Prathamesh is listening, and Prathamesh always gives me, sir, use cautery. And I will say, Prathamesh, reason I don't, because in Chikaldara, our cautery, the electrical fluctuations are great, the current is not stable, you can get literally fire working everywhere, and look at the amount of damage you can create. And this we have studied on histopathology, that the damage is black, which is primary, but the lateral damage is yellow area, which also shows that the capillaries are gone there. And therefore, if you put those circles on the structures on your right picture, then you can easily imagine how badly you can damage the recurrent nerve or the parathyroids. Now, last thing before I close the slides and the lessons learned from there is when somebody goes to a meeting and they can hear the next debate which is going to come on about the Hemi versus total, which is never satisfied, and you only create enemies and you fight, and your beer is spoiled because the person in front of you has said that he will do a total and you had said a Hemi. But the real dividing line is how safe can you get that picture in every single thyroid you do. And if you are so confident that yes, I can get the parathyroid looks nice and yellow, maybe caramel, I can see the nerve just maybe a centimeter or so, yes, and deliver the thyroid safely, maybe go in favor of the total. But if not so, and if you are not so confident, I should be more safer in performing lesser surgery. Now, a word from a civilized area to a non-civilized area, I have a statement that denying technology would be ignorant. So I will not say ever that remote control robotic is not on for me. But at the same time, I will say years of wisdom that you gather by doing open surgery should not be neglected or ignored. Now, paradox of technology. Look at this picture before I shut down for next 3-4 slides. There is Greg Randall showing beautiful intraoperative monitoring, wearing beautiful binoculars, wonderful headlights, everything. But in the evening, Professor Randolph goes off into this hamlet and distributes solar lamps because those people have never seen light after the dawn, after the sunset, because they don't have electricity. See the paradox of technology. On one hand, you have got a nerve monitor. On the other hand, you even do not have an electricity. So you got to make a judgment for yourself. Now, looking at this picture, our journey of 2 decades, anybody would say, but what's that for me? I mean, what's the Western world has to learn from you? I will say what contributions we have made from Chikaldara to the world are very few, but undoubtedly proud to tell you what those few contributions are. The contributions are, we developed a technique called cervical epidural anesthesia. And It's a safe technique, proven several times over in the camp. The patient literally walks. This is not like a Chinese red book, somebody reading and the surgeon performing a thyroidectomy. No, this is not hypnotism. This is scientific. And my wife developed this technique, and we greatly owe her to her, because there's a technique which enables us to do several thyroids in one day, almost like a conveyor belt. Now, the next thing that came off from there is something similar to the next generation, that is Niti and Abhishek. And they got on with this idea that let's put it together what the technology or the advanced investigations are going to tell us, and came out the genesis of impact. And I'm sure they will allude to this later on in the discussion. We also managed to produce 2 books, the Atlas, which was the very first Indian Atlas on thyroid surgery, and of course the Principles and Practice, where everybody, Professor Shah, Professor Tolley, a lot of people from the world has contributed. But proud to say that the authors came to us saying they want an Indian version. So that's what Chikhaldara did, even to the people abroad sitting in London. Now, this is a brief view of what the cervical epidural anesthesia is all about, that you give a epidural space in 7-8, and that's done with a catheter which was put in, and Lord behold, what you get is this. You can remove that thyroid, huge goiter, and give her a drop of water to drink at the end of the day. I will not recommend this for everybody to do everywhere in the world, but definitely horses for courses. You can definitely do this technique in Chikhaldara. The patients are rugged. We are comfortable operating. My wife is comfortable giving the anesthesia, and we can turn them over about 10 to 12 patients in a day. Now, this is what impact is, and maybe the world will see more of it from Niti and Abhishek in future. These are the books I alluded to, and we have trained 654 thyroid young surgeons which are practicing in all parts of India, and we regularly get feedbacks from them. And I always tell them, I'm only a phone call away if you are stuck. And I'm very happy to say that in the beginning, they will be probably calling me before every surgery or after every surgery. But gone 6 months, I don't get a call, and then I get worried. Have they forgotten me? No, they haven't forgotten me, but they have mastered the technique. And that's what the best reward you can get for conducting camp in a remote place like Chikhaldara. Now, these are the other places where from people come, and we have now sort of said that if you are interested, you can do it, because if we could do it, anybody can do it. Now, some remarks, that is my friend Bill McNichols. I'm sure now maybe, Neil, you can probably have bumped into this gentleman. He's my age. We were co-registrars in Birmingham, and he went on to become consultant in Mansfield. And he came there, Greg Randolph came there, and almost Twente became speechless. Before I say the last words is this, that when these people come to the camp and the thyroid workshop, all I say to them is, they have the trust, so I must do my best. And we have to deliver them back home safely. I'm sure on that audience, Prathamesh has been there, Jyoti had been there, Neil had been there, and God willing, one day we'll get Ashok there as well. Anyway, thank you all very much. We move on to the next topic, which is a debate. Now, the debate that haunts all the ENT surgeons, particularly those who have got into the thyroid surgery and those who attend the meetings fairly frequently, is yeah. And before that debate, we have the other side of the story to hear. And the other side of the story is what is happening at the ivory towers. So Neil is privileged. He has worked in a rugged hill with little or next to little things at his disposal, whereas he also works in the best of the best in the world. So Neil, I would like you to share your views about the outcomes and how they compare from what you worked in Chikhaldara. So after Neil's talk, which will be probably a completely different tone and setting from what you're seeing, we will move on to the debate. So Neil, would you please take forward?
Well, Madam, thank you very much. I thought I got away with presenting there, but obviously not. Look, always difficult to follow Dr. Capre's lectures. I've been fortunate enough to go to Chicaldra not once but twice, and it was a wonderful experience for me, and I also got a great deal of learning from it. My remit is to talk really about outcomes in thyroid surgery, and it's really going to have a bit of a different spin on it, and it is going to talk about the haves and have-nots. And so the lecture is really going to talk about outcomes initially from an historical perspective. And then we'll talk about the time of the have-nots in the 19th century, and have-nots can come in different guises and different forms, and I'll expand on that shortly. And then I'm going to talk a little bit about where we are now in the times of the haves, and then finish with a summary narrative. So you've just really got to reflect on where we were in the 19th century with thyroid surgery. In the 19th century, we didn't even know what the function of the thyroid gland was. If you look at some of the older surgical textbooks, you'll often hear it referred to eponymously as the bronchocele. And it was called the bronchocele because they actually thought at that time that one of the functions, or the function of the thyroid glands, was actually to lubricate the vocal cords. We know very well that the thyroid has a relationship with the larynx, but it wasn't to lubricate the vocal cords, it was to move them. We didn't understand what its function was, and even the term myxedema wasn't coined until the 1870s. And the relationship between myxedema and cretinism and the surgical effects of thyroidectomy, that link wasn't made until the 1880s. The parathyroids hadn't been discovered until the late 19th century. And their function wasn't defined until 1909. So you can imagine that all these patients having thyroidectomy in the 19th century, having all sorts of problems with tetany, there was no blood transfusion, no electrocautery, and also not the facilities that we take for granted now. So we just have to reflect really on what it was like then. So the outcomes in the 19th century were based on whether the patient survived. In fact, the outcomes in the early part of the 19th century were so poor that it was banned by the French Academy of Medicine in 1850. Halsted, who Dr. Capra has already alluded to, worked at the Johns Hopkins Hospital in Baltimore, cites a 40% mortality in 70 pre-1850 references. Extraordinary. And then the pioneers, Theodore Billroth, Theodore Kocher, who's regarded as the father of modern thyroid surgery, you can see that they went through a learning experience between the 1860s, the preceding decades. Billroth, for instance, in his first 20 patients had a 40% mortality. Even the great Kocher had a 13% mortality in 101 patients in 1883. But he managed to get that down to less than 1%, which is really extraordinary thinking on what facilities were available at that time. And for his great work in thyroid surgery, he was the first surgeon ever to receive the Nobel Prize in Medicine and Physiology in 1909. And his mortality, operating on over 5,000 patients, was only 1 in 200. And just try and lock that 1 in 200 mortality into your head, because I'll come back to that later on. So the have-nots in the 19th century, they had no knowledge whatsoever of the physiology of the function of the thyroid gland. Obviously, anesthesia, antisepsis, instrumentation, even things like caps, gowns, sterilization. These were all technological developments that occurred within the 19th century, and they made surgery much safer. In the early part of the 1890s, for the first time ever, we had a treatment for myxedema using sheep thyroid extract. But again, the relationship with the iodine and thyroid function wasn't really elucidated until 1907. So these results by Kocher were quite extraordinary when you think that he was operating on the hands in an era where our knowledge was very poor. Knowledge of the parathyroid, once again, not elucidated until 1909. I just want to show you this video clip. This is a video clip of Eugene Doyle, who was a surgeon working in Paris in the late 19th and early 20th century. He died in 1960, so I think this video clip probably was the early part of the 20th century, looking at his age. But just reflect on the have-nots and what they had in those days, and it's quite a profound experience. So he's obviously operating on a colloid goiter. No mass, no gowns. He actually was at the forefront of developing electrosurgery, but there was no electrosurgery there. You see the anaesthetist using chloroform. You'll see him open the sac now of the colloid cyst. So this was certainly surgery in the area of the have-nots. Thyroid surgery in 2020 is very much outcome driven, and Madam beautifully demonstrated his fantastic pioneering work in Chicaldra. But really, there is great onus on the surgeons that operate on these patients in the rural areas where the facilities are quite primitive. These patients can't afford to have any complications. So the outcomes are absolutely critical for these patients, because otherwise we've got a great risk in making the patients work. So our outcomes in terms of bleeding, vocal cord palsy, and permanent hyperparathyroidism, I want to expand on some of these now. And our knowledge is very much being brought about by the collation of big data. We've heard that there are now 4 databases in India. We've got a UK registry of endocrine surgery, and there are even bigger databases. And when you collate all these surgical operations, that's really when you get a good feel, a good granularity of what the true complications are for thyroid surgery. And we just have to aspire to get our complications down to 0% as a surgeon for our patients. So this is looking at bleeding for total and hemithyroidectomies, and this is based on the UK Registry of Endocrine Thyroid Surgery. It's going to be data from well over 40,000 thyroidectomies. And you can see that you've got a higher risk for bleeding if you're male, if you've got a toxic thyroid, if it's revision surgery. Total thyroidectomy compared to hemithyroidectomy also has a high risk. If the primary operator is a consultant, someone who's more experienced, the risk of bleeding is less. And if you've got a retrosternal goiter, also the risk of bleeding is greater. If we split this up now, looking at hemithyroidectomy, because the Beats, my organisation in the UK, have now supported that certain hemithyroid procedures can be considered to be done as a daycare. So this is important in terms of using hospital resources, and it's particularly relevant in the pandemic era. So when we look at male, again, you've got a high risk of hemorrhage, revision surgery, and a retrosternal goiter. So these are probably not cases that you'd want to consider doing daycare surgery. And the older the patient, also the more likely they are to have bleeds and return to theatre. So going on to vocal cord palsy now, we see that, again, looking at big data, that you are more likely to sustain a vocal cord palsy if you're operating on a retrosternal goiter. Very relevant to the work at Chicaldra. Again, revision surgery. And this is why we very much advocate for global pathology and multinodular pathology, then total thyroidectomy rather than some form of subtotal procedure should be the modus operandi. Total thyroidectomy also increases the risk for vocal cord palsy, as does nodal dissection. And we've actually found that in the large databases that we have, that using the laryngeal nerve monitor, and Greg Randolph would love this, that it does actually decrease the risk of vocal cord palsy. And this is supported by other databases, such as the Swedish registry. and it does actually decrease the risk of those. We very much recommend that all thyroid patients have both a pre and a post-op laryngeal examination. I think it's particularly important preoperatively if they've got voice change and you're considering malignancy, because that very much will affect the informed consent process. It will also affect the planning. You may want to do a CT scan of the trachea to make sure there isn't invasion of the trachea, because we know that a vocal cord palsy is very specific for the finding of extracapsular breach of the thyroid cancer. Unfortunately, not all surgeons in the UK are doing pre and post-op laryngoscopy, and there's a lot of data missing. But if you look at a lot of the literature, they'll say that the vocal cord palsy rate is 1% or less. Well, big data is clearly showing that isn't the case. So overall, we'll get a percentage of 3%. Those that had laryngoscopy, it was about 5%. And the more you do a post-op laryngoscopy, the higher the percentage rate. So those cases that routinely had patients where in over 80% they had a post-op laryngeal examination, the incidence of vocal cord palsy was 6%. And if you do a laryngoscopy before the patient's discharged from the hospital compared to testing it at week 2 or later, you find that the incidence of the vocal cord palsy is also higher in an inpatient setting. In fact, it's double if you do a laryngoscopy as an inpatient before discharge, but fortunately, about 70% of these are temporary. In those patients that consistently had a pre and post-op laryngeal examination, okay, 100% data set, we found out that post-operative vocal cord palsy rate was just under 8%. And you've got to consider that this is data, by definition, from the work of surgeons that are interested in thyroid surgery. They are members of the British Association of Endocrine Thyroid Surgery, and they engage with entering their data. So clearly, in the general community, the vocal cord palsy rate is likely to be much higher. There are other databases. This is a CRAB database, which involves operations that are collected from 36 different countries, 14 million procedures. Not all of those are thyroidectomies, and it predicts individual complications and mortality. And the great thing about this data is that it's validated looking at the ICD-10 codes. So the CRAB data, the Hez data, which is all the thyroidectomies that are done in England, and the UK registry, the BEATS audit, these are shown in these 3 columns. What we see consistently, if you look at the literature, is a stridor rate of 0.4%. And to get stridor, you've got to have a bilateral vocal cord palsy. Interesting that the mortality has also been shown to be 1 in 1,000. That's been shown on the Hez data. That's all the thyroidectomies that are performed in England, and also the UK registry. But if you look at the overall 30-day mortality, it becomes 1 in 167 and 1 in 334. And going back to what Coker achieved in the late 19th century, he got his mortality down to 0.5%, 1 in 200. So again, a remarkable achievement. So if we extrapolate the stridor rate, that will be consistent with a vocal cord palsy rate of about 6.35%. And clearly, therefore, the complications are much higher. If we look at the Hez data for total thyroidectomy, it's a very noisy slide, so just concentrate on the first column, total thyroidectomy. Look at the incidence of hypoparathyroidism. It's just over 11%. Diagnosis of stridor within 1 year of thyroidectomy, 0.6%. Again, it's that figure, 0.4, 0.6%, which would equate to a vocal cord palsy rate of at least 6.6%. And what also is shocking, that the incidence of either temporary or permanent tracheostomy within 12 months is 1.4%. Okay, and this is looking at just under 23,000 patients. And this has also been supported by some literature findings. If you look at this study by Weiss et al., looking at a large California database, their incidence of tracheostomy in 107,000 patients was 1.62%. So you may think, okay, well, vocal cord palsy happens, we can treat it. What's the problem? Well, the problem is that if you sustain a vocal cord palsy, it has morbidity. They can have voice problems, they can have swallowing problems, but it also has mortality. So this slide shows the incidence of readmission to A&E as a result of a chest infection following thyroid surgery. And A shows those patients with a vocal cord palsy that's untreated. B is a vocal cord palsy following their thyroid surgery that is treated. And C is just the total thyroidectomy control, assumed to have no vocal cord palsy. So it shows that if you've got a vocal cord palsy, you're much more likely to be admitted with pneumonia, certainly within the first 12 months post-surgery, but it continues for many years following their surgery. And the earlier you diagnose it, the earlier you treat it, the less chance that they have of being admitted as an emergency with a lower respiratory tract infection as a result of aspiration. But it never returns to a normal baseline. So vocal cord palsy, although they can have rehabilitation from a voice perspective, it is a long-term issue that they carry with them in terms of risk. Now that is the morbidity. But even if we look at mortality that applies, so if you've got a vocal cord palsy, you're more likely to have an earlier death. And if you've got a vocal cord palsy and it's treated, then it's less likely compared to those patients who don't have a vocal cord palsy, but have, again, a history of a total thyroidectomy. So just again to reiterate that if you've got a vocal cord palsy, this is not a small complication. It has early and late implications for the patient in terms of morbidity, but also mortality. So what about hypoparathyroidism? Well, this again is showing you the data from the UK registry. We actually have defined temporary hypoparathyroidism as a corrected calcium on day one of less than 2.1 millimoles per litre. And we find that if you do a total thyroidectomy for a multinodular goiter, it's around about 22%. Revision surgery increases that. So again, it reiterates that decision-making process. If you've got global pathology, then the primary index surgery is the time when they're going to have least complications. If they have a nodal dissection, particularly a level 6 dissection, you can see that the incidence of temporary hypocalcemia is huge. And total thyroidectomy for all pathologies is about 27%, and that is on a temporary basis. But when we look at the late issues of permanent hyperparathyroidism, very relevant to a population of the have-nots in Chicaldra, it's 12% in the fourth audit and 6.5% in the most recent audit. So it is a considerable number of these patients that have long-term morbidity and even worse, which I'll come to very shortly. And there's a definite trend for low rates of permanent hypoparathyroidism in the high-volume surgeons. The Scandinavian Quality Register looked at just under 5,000 patients, again looking at the issue of permanent hypoparathyroidism. It doubles the mortality. It increases 5-fold your risk of renal disease. You also have the issue of adynamic bone disease, increased risk of cardiovascular issues, cataracts, calcification, and also, a somewhat surprising finding, it doubles your risk of malignancy. So again, permanent hypoparathyroidism, it has early and late consequences for the patient. So this is the narrative summary. Are outcomes in the have are they have and haves not dependent? Does technology significant impact on outcomes, such as nerve monitoring and energy devices? Well, all the evidence would stipulate from the literature that it indicates technique, specialization, and volume are the main primary outcome determinants. In other words, experience. They are far more important than the energy devices, the nerve monitors that the haves in the ivory towers or in the big hospitals. So training, personal professional development, courses, critical appraisal, audit, very, very important drivers to allow us to improve as surgeons so that we can get the best possible results for our patients. And if we achieve that, then we can deliver this care to the have-nots in Chicaldra. So it's very, very relevant in the context of what Dr. Capre has just presented. So almost second to Dr. Shah's slide of him being a taxonom is this statement. It's really an iteration of Oscar Wilde, the playwright statement, and it's very true that experience, the term surgeons use to describe their mistakes. It's very apt today as it was in the 19th century. It's been a great honour and a great pleasure always. I feel that I don't need to be introduced any longer because I feel that many of you now are my friends, and I feel that I know you all so well, but it's been a great pleasure to participate in this webinar. And I hope you enjoyed my garden, just as you might talk, hopefully. Thank you.
Lovely. Very nice. Thank you very much, Neil. I think it was fantastic. And this is what we always expect from you, is to give a very critical analysis of the facts of the post-operative things. And of course, also analyzing it to a level where it becomes practical. And I'm sure all those who are listening to Neil will benefit enormously. And they are free to ask questions to all the people who are going to talk now and later. And I'm sure Vijay will be monitoring those questions and then sending over either to me or ask you those questions directly. So thank you very much, Neil. I can't ever let you go without sharing or knowing from you what you have to say. Anyway, welcome. And thank you again. And now I invite the young, sort of aggressive guys amongst us, the new budding surgeons, Abhishek and Niti, to debate out whether to do a hemi or a total thyroidectomy for various types of well-differentiated thyroid cancer. And this debate is particularly put in because I have already said that nothing gets decided till cows come home. And at the end of the debate, you only become an enemy and lose either one or two or maybe many friends in the audience. So saving you doing that, let the young guy speak, and then the Godfather will come. The Godfather from New York will come on. I'll save you for that. Professor Shah will be commenting upon how they are said and probably elucidating to if anything is missed out. So the first come first, Abhishek will go on, and Abhishek will try to tell you how best it is to do a hemithyroidectomy to give the best to your patient. All to you, Abhishek.
Thank you so much. I am overwhelmed by the presence of absolute luminaries of thyroid surgery here. So the issue we were debating today is what is the optimum surgery for differentiated thyroid cancers, and I've tweaked that scenario just a bit. Because the actual debate is what is the optimum surgery for unilateral low-risk differentiated thyroid cancers. And I plead today that the optimum surgery for such a thyroid cancer is hemithyroidectomy. So I think this is a debate which refuses to die, and this is amply evident from the fact that 5 years after the American Thyroid Association came out with the guidelines in 2015, we are still debating this. Nevertheless, here we are today, and I have to put forth my points. At the outset, let us understand what the debate is, what the debate is not about, and what it is about. So this debate is not about bilateral disease, aggressive variants, high-risk group disease, or high-risk group patients. Because in these, we would certainly be doing an aggressive surgery, which could be a total thyroidectomy. This disease is about unilateral disease, low-risk group disease, and a low-risk group patient category. In fact, 70 to 75% of all thyroid cancers are what comprises this group. So this is a very pertinent debate that we are speaking about today. And this is a typical case scenario. This is a young girl, 18 years old. She's got an anterior neck swelling since about 4 to 5 months. It's a solitary thyroid nodule, 2 by 2 centimeters in size. There are no neck nodes. The ultrasonography also confirms that. And the fine needle aspiration is papillary carcinoma thyroid. So the debate is, what would we do for such a patient? And that is what I'm going to speak about. So what do I plead today? I plead that hemithyroidectomy results in equal survival as total thyroidectomy for most thyroid cancers. And remember, I'm speaking about low-risk thyroid cancers. The recurrence in the opposite lobe, once you've done hemithyroidectomy, are very few. They're less than 5%, and they can be well tackled by a subsequent surgery. Hemithyroidectomy is certainly safer and it is less morbid. Radioactive iodine therapy is not required for most low-risk thyroid cancers, and it should not influence the extent of surgery. Remember, we are once again speaking about low-risk thyroid cancers here. Further, thyroglobulin monitoring is not once again required for low-risk thyroid cancers, but if required, it may be done even after a hemithyroidectomy. And as is the nature of debate, I'm going to put forth data, and I want to appeal mostly to your logic and less to rhetoric. So these are the bone of contention we are talking about, and I've marked them in green and red. So green is the point I'm arguing for. I'm arguing that hemithyroidectomy is a much safer surgery. Red are the points which I'm defending against, which those proposing total thyroidectomy might suggest. And what are these points? These are outcomes with respect to survival and recurrence, the ability to use radioactive iodine after surgery, and the ability to use thyroglobulin for follow-up. So let's tackle these points one by one. We only have 10 minutes, so I won't be going through the details of each study, but I'll just put forth the salient features. So safety of surgery. Before we move on, remember the oath we took. At the foremost, do no harm. Primum non nocere. And I want to submit that a less harmful surgery is hemithyroidectomy. And this is amply evident from a lot of data all across the world. We know that hypoparathyroidism, whether transient or permanent, is much less common in hemithyroidectomy as compared to total thyroidectomy. Recurrent laryngeal nerve palsy, even unilateral, is less common in hemi as compared to total. Bilateral is, of course, a complication unique to total thyroidectomy, and it can indeed be life-threatening. Other complications such as seroma, hematoma are also lesser in hemithyroidectomy. Hospital stay is shorter in hemithyroidectomy, and the issues associated with the use of radioactive iodine ablation are avoided in hemithyroidectomy, as also the issue of TSH suppression. But don't just take my word for it. This is one of the largest sampling of complications vis-a-vis unilateral versus bilateral thyroid surgery. And this is from the National Inpatient Sample Database. Close to 14,000 patients the complications are mentioned here. And it states very clearly, and I've marked it here, that hypocalcemia as well as hypoparathyroidism, both temporary and permanent, is significantly more common in total thyroidectomy. Vocal cord palsy, both unilateral and bilateral, is significantly more common in total thyroidectomy as compared to hemithyroidectomy. The hospital stay as well as the cost of treatment was more in total thyroidectomy, and all of these are statistically very significant. On that note, let's speak about expert hands. And we often speak about thyroid surgery being performed by expert surgeons and non-expert surgeons. So what is the definition? The US definition of this is someone who performs about 50 surgeries per year. But the truth of the matter is that the so-called non-expert surgeons are the ones who are performing a lot of these thyroid surgeries. And we know that complications will be more with less experienced surgeons. So what is the solution? Is the solution that all thyroid surgeries be performed only by expert hands? This is not practical, and this is not something which can be suggested or purported. The other point is hemithyroidectomy is a safer surgery, and therefore for low risk thyroid cancers, the initial surgery should be hemithyroidectomy, and it can be therefore much safer even in non-expert hands. So the point I want to make is weigh the very small benefit, potential benefit, against a large potential of complications which you will do while doing total thyroidectomy. Let's move on to points number 2, 3, and 4, and these are something which I am defending against. These are points in favor of total thyroidectomy, but I want to defend them. What about outcomes with regards to recurrence and survival? So let's agree that there is no level 1 data or randomized control trial comparing hemithyroidectomy and total thyroidectomy, and given the large number of patients which will be required to do such a trial, there probably never will be one. So we have to depend upon institutional reviews and large databases. All of these are retrospective in nature, and at best, they are level 2B in evidence. So let's analyze them one by one. Let's first look at institutional reviews, and on your left are those favoring total thyroidectomy, on the right are those favoring hemithyroidectomy. And a lot of big names from the top-notch institutions in both the columns. So all in all, it looks like a picture of total equipoise. You might just as well take one set of studies and compare with the other, but it's a picture of total equipoise when you compare just the institutional reviews. You therefore will have to depend upon databases, and there are two kinds of databases which I'm talking about today. The SEER database, which is a surveillance, epidemiology, and end results database, and the NCDB, or the National Cancer Database. Both of these databases are American databases. Professor Doyle spoke about British databases as well, but these are mainly American databases. The SEER database has been analyzed several times, and I've just mentioned a few of them here. And all of these found a difference in outcomes between total thyroidectomy and hemithyroidectomy when recurrences and survival was compared. With regards to National Cancer Database, one of the earliest evaluation was done by Handal in 1998, and which concluded that there was no difference in survival or recurrence patterns between the two kinds of thyroidectomies. It was evaluated again, and the results were published by Villemoria in 2007, which showed that there was improved 10-year survival in patients undergoing total thyroidectomy, and the result was especially evident for tumors which were more than 1 centimeter in size. So based on the Villemoria paper, the American Thyroid Association guidelines in 2009 stated that for all thyroid cancers who are more than 1 centimeter in size, the initial procedure should preferably be a bilateral extirpation, or total thyroidectomy, or a near total thyroidectomy. But if you do a little nitpicking into that paper, and I've just put out one Kaplan-Meier curve here, if you look at the two groups, they are separated by a very narrow margin. If you look at the total thyroidectomy group, the 10-year survival was 98.4%. In the hemithyroidectomy group, the total survival, the 10-year survival was 97.1%. The difference was just 1.3%. And the moot point here is whether this was clinically significant survival difference for the American Thyroid Association to recommend total thyroidectomy in most cancers, differential thyroid cancers who were more than 1 centimeter in size. The American Thyroid Association subsequently in 2015 reviewed their guidelines. They changed them with regards to the extent of surgery for cancers which are more than 4 centimeters in size, or who had high-risk features such as cross-extrathyroidal extension, or nodal disease, or distant metastasis. It is obvious that a near total or a total thyroidectomy was suggested, but the important point was point B, and I've highlighted it here, that for thyroid cancers which are more than 1 but less than 4 centimeters in size, without any high-risk features such as ETE or lymph node metastasis or distant metastasis, thyroid lobectomy was considered to be an acceptable initial treatment. So this brought about winds of change, and this is something which was reflected in how surgeries were performed across different surgeon groups in the US, and this is data from the National Surgery Quality Improvement Program. And as you can see, after 2015, there was an increase in the number of hemithyroidectomies which were done in the US. This increase was seen for all kinds of surgeons, both otolaryngologists and general surgeons. Otolaryngologists, as it is, had a baseline higher proportion of hemithyroidectomies. So overall, the number of hemithyroidectomies really saw a splurge after that paper. The next point which I want to negate is the ability to use radioactive iodine ablation. Remember at the outset I said that we are speaking about low-risk thyroid cancers. And once again, the question here is radioactive iodine therapy really needed for low-risk thyroid cancers? And there are a lot of papers which have come forth now which kind of negate this idea that low-risk thyroid cancers need not be treated with post-operative radioactive iodine ablation. The point to drive home is that there is no survival difference by using radioactive iodine therapy in low-risk cancers. And this is something which is reflected in the American Thyroid Association guidelines once again. It is only for the high-risk cancers where radioactive iodine ablation is recommended based upon good evidence. For tumors which are between 1 to 4 centimeters in size, but which have other high-risk features such as lymph node metastasis or higher risk pathology, old age, male gender, they recommend based upon moderate quality evidence. But for low-risk thyroid cancers, mind you, this is the group we are talking about today, the ATA does not recommend post-operative radioactive iodine ablation. So that brings us to the next point, which is whether a total thyroidectomy should be done so that we can follow up better with thyroglobulin. The ATA guidelines are once again clear. Thyroglobulin monitoring should be done or thyroglobulin follow-up should be done in patients undergoing a total thyroidectomy, and it may only be considered in patients undergoing hemithyroidectomy. But there is a counter view to that. A thyroglobulin can be used for follow-up even in patients undergoing hemithyroidectomy. And I've just put out a couple of studies. There are several such studies which says that thyroglobulin is useful even in patients who have undergone less than a total thyroidectomy and without subsequent radioiodine ablation. So once again, the point to drive home is that a decision to do a total or a hemithyroidectomy should not depend on the ability to monitor post-operative thyroglobulin levels. A note about completion thyroidectomy. Let us concede that local recurrences will be seen in less than 5% of those who have undergone hemithyroidectomy. But the important point is that these can be tackled very well with surgery. And there is increasing volume of data on the safety and feasibility of completion thyroidectomy. In the interest of time, I won't go through the details of the study, but most studies would kind of reiterate the point that the safety of completion thyroidectomy is good. And the morbidity pattern is probably no different from what you would see in an upfront total thyroidectomy in expert hands. So to conclude, I would like to say that high-risk patients should undergo total thyroidectomy, and there is no debate about that. However, most patients with thyroid cancers are low-risk cancers and they have an excellent prognosis. For low-risk patients, outcomes after a hemithyroidectomy are comparable to total thyroidectomy, except for one study, which was Bilimodia, and we've just seen that it had a number of potential fallacies. The role of adjuvant treatment in the form of radioactive iodine is not well defined, and therefore it should not be a pivot which would drive you towards total thyroidectomy. Radioactive iodine ablation as well as thyroglobulin monitoring may not be required in low-risk thyroid cancers, and it is this group which can be spared the morbidity of total thyroidectomy. We know that there is an increased risk of complications with total thyroidectomy. We also know that occult multicentric tumors will be present in about less than 5%, but whether these are clinically important is the question, and these probably are nothing more than laboratory cancers. Recurrence in the opposite lobe arises in about 5% of the patients who undergo hemithyroidectomy, but this can be tackled very well with a subsequent completion thyroidectomy. But eventually, patient choice is the key to decision making. And Dr. Shah is here, and I would like to quote his statement about hemithyroidectomy. It's excellent that if you can do a good total thyroidectomy, but an operation not worth doing in selected patients is not worth doing well at all. Before I end this debate, I would like to say that our concerns with regards to how we provide patient care move beyond this debate. And the real question is, what exactly does your patient want? And this is a very telling paper. This was published in 2019. It compares long-term quality of life between hemithyroidectomy and total thyroidectomy in patients who were treated for low-risk DTC. And in conclusion, they said that patients who undergo hemithyroidectomy may probably have more anxiety about the risk of cancer recurrence. So if it seems that I'm playing right into the hands of my opponent, that's really not the point of this debate. The point is to provide better patient outcomes and satisfaction, and it really needs to be seen whether patient satisfaction and quality of life alone and anxieties can be a hypothesis generating point when we consider doing Hemi or total thyroid. Thank you so very much.
Thank you, Abhishek. I think that was an excellent sort of arguments all around, and I'm sure your audience is convinced about doing a hemithyroidectomy. But now let's listen if it can be shaken. And can you now say if I'm convinced? Maybe there could be some facts coming forward from the opposite side who might be supporting a view completely or diagrammatically opposite to yours. So let me invite Niti Kapre Gupta to put forth his views, her views, where she would say or try to convince you that no, that's not correct. You should do total. So let's see what she has to say. Welcome, all yours.
Thank you very much, and thank you, Abhishek, for making my life more difficult. And well, I wasn't having butterflies up till now, but now the story is a little different. Anyways, thank you very much to all for signing in. Just like Dr. Kapre said, I don't think the cows are coming home on this one. They just refuse to come home, and the debate goes on. What we have managed to do, however, is we've managed to narrow our debate down. So just as Dr. Abhishek said, on the extremes, we've sorted things out. And the jury is still out only for the select group of patients, 1 to 4 centimeter cancers without documented extranodal extension or nodal metastasis. And these are my arguments that I should be using. Survival, well, you've just heard my co-debater saying that there is equivocal survival outcomes on either side. I concede to that. But differentiated thyroid cancers, as the teaching goes, is a forgiving disease. It's a good biology. So more than mortality, it is the morbidity that is the bone of contention. Morbidity of recurrences, morbidity of a potential requirement of a completion thyroidectomy, the morbidity of the procedure itself. And let's look at these in the subsequent slides. Softer arguments about the correct, not injudicious application of iodine and a follow-up with thyroglobulin are also something that we're going to look at. If you see some repetition, bear with me, because what we're trying to do actually is to present you two sides of the same coin. So you're going to have equal data supporting a hemithyroidectomy point of view and equal data supporting a total thyroidectomy point of view under the same headings. But let's see if we give you some food for thought. Now, I have some data to back my side of the motion, wherein the legendary Ernest Mazzafari came out with this paper in 1994 and said anything, any surgery more than a lobectomy was sure to give you a better cancer recurrence-free survival and a better cancer-specific mortality. Again, National Cancer Database telling you a 10-year survival was significantly better with the total thyroidectomy. But I won't give you a lopsided, untrue picture. I concede it is an evil playing field when it comes to survival outcomes. And that's why we have reputed institutions telling us one way or the other. You'll save equal number of lives whether you do a hemithyroidectomy or a total thyroidectomy. But that's not really the question. The question remains recurrences, because that's the morbidity that differentiated thyroid cancers carry. And here, few can debate the supremacy of a total thyroidectomy. Professor Ian Hale from the Mayo Clinic said that total thyroidectomy or a bilobar resection was statistically significantly better to give you local regional outcomes. Again, a large data, more than 16,000 patients published just a few months ago saying the same thing. Look at the p-values on the extreme right. A statistically improved recurrence rate with a total thyroidectomy. Sometimes these p-values and Kaplan-Meier curves, although interesting read, can become intimidating. And what we need in day-to-day clinic is something more user-friendly. So we need somebody to analyze all of this data and give us some clear recommendations. And that's exactly what this body, the American Thyroid Association, has been doing for a century now. So let's see what they have to say about this. The latest guidelines, 88-2015 for differentiated thyroid cancer, The initial surgical procedure can be a bilateral or unilateral. If you read the recommendation in entirety, it's extremely comprehensive, but what it tells you is the debate is far from over. We all know 88/2009 said anything above 1 centimeter, you should probably do a total thyroidectomy. So what changed in the 6 years? And this safety that has been awarded to a hemithyroidectomy in terms of survival probably can be largely attributed to this landmark paper published in 2014, few months before the new guidelines came out. More than 60,000 patient data where they said extent of surgery for papillary thyroid cancer is not associated with survival. But let's look at the fine print, and you will soon realize that it was the patient selection and not the type of operation that had a bearing on the outcome, because the good tumors, the smaller ones without multifocality, without nodal metastasis, without ETE, were likely to undergo a hemithyroid, and the bad ones were much more likely to undergo a total thyroidectomy. If you look further into the paper, we can see that the overall survival improved with a total thyroidectomy as the size of the tumor increased. Limitations of the study: there's no data on recurrence or completeness of resection, which are key prognosticators, and they've clubbed completion thyroidectomy with total thyroidectomy for their final analysis. In my viewpoint, completion should be clubbed with hemithyroidectomy because that was the initial planned operation. There were multiple letters of editor after this paper was published, and the lead author, Professor Sosa, in one of these letters replied that we are not recommending hemithyroidectomy as the operation of choice. We're saying that one needs to practice thorough preoperative evaluation and risk stratification. Sure, let's do that. If you look at all of these risk stratification scores, majority information is available only after the surgery is over. You can't say with certainty about histological grade, bad variants, ETE, multicentricity, or even nodal metastasis sometimes till the histopathology report lands up into your hand. Mind you, let us not disregard the prevalence of contralateral tumors. In special biological variants like FBPTC, it can be as high as 30%. In this subgroup where they looked at 120 such patients, they found that more than 10% of these were macrocarcinomas, not really lab cancers. They were sitting there in the other lobe undetected, and had they remained there, sooner or later would definitely have caused a clinical problem to the patient. Other high-risk features, again in the same subgroup, 1 to 4 centimeter well-differentiated thyroid, like aggressive histology, angioinvasion, can compel you to do a completion thyroidectomy in as high as 40% patients. So we concede that completion thyroidectomy is an avoidable evil. Another wonderful paper from the MSK group where they found a rate of 30% completion thyroidectomy, majority of these were actually totally low-risk cancers. They offered surveillance to 15 out of 79 patients. Don't worry, it's not a detriment to your health or safety by doing a hemithyroidectomy. We'll just keep monitoring you. But ultimately, all of these patients refused surveillance and opted for a completion surgery. Let's look at data close to home. Amrita paper, they analyzed patients 1 to 4 low-risk thyroid cancer and found that 60% would warrant completion after a hemithyroidectomy. In an Indian scenario, it's not just a simple change in the surgical decision. It has implications on hospitalization. Patients are bad to follow up. There is a problem of repeat expenses, let alone the emotional trauma to the patient and the relatives. If there weren't enough funny jokes on the internet about a doctor leaving his cell phone behind in the patient and then going back to retrieve it, I think if you tell your patient, I'm going back to retrieve a potentially tumorous tissue, it's not going to be that humorous. And of course, preoperative surgery is fraught with an increasing degree of complications. This was a paper published in 2019 where they found that preoperative thyroid surgery had significantly higher rate of hypoparathyroidism and RLM injuries. And to conclude on the topic of complications within this slide, this I told you, Abhishek can pull out data of some 10,000 odd patients saying total thyroidectomy is unsafe. I can pull out data saying it's safe. So again, same coin, two sides. It's not that simple in arithmetic that if you do a total thyroidectomy, instead of a Hemi, your complication rate doubles. Look at these numbers. And now let me take you back to the slide on reoperative. So if you've done a Hemi, there was a recurrence, or you had to go in to do a completion, that is a reoperative thyroid surgery, the rate of complications, in fact, increases by more than thrice with the same arithmetic logic. Now let's move on to the other 2 points. By no means are we advocating a performance of total thyroidectomy just to encourage an use of RAI or to ease your follow-up with a thyroglobulin. That's not definitely the rationale. Less is more. But one should know when less really means more. And this sentiment is beautifully echoed in this consensus statement by the American Thyroid and the European Thyroid Association and the Association of Nuclear Medicine, where they said we still don't have enough data to refute the role of RAI even in low-risk patients, because it's not the effectiveness or ineffectiveness of RAI in these patients, it's our ineffectiveness to detect and identify the true low-risk patients who have residual disease or bad pathology, and we're missing them out by not giving them RAI. Again, more data to tell you that you have a better overall survival with RAI, which of course requires a performance of a total thyroidectomy, even in an intermediate or a low risk setting. Coming to follow-up, the value of thyroglobulin as a tumor marker is unquestionable. After a total thyroidectomy, the guidelines recommend you do a thyroglobulin every 6 to 12 months. But after a hemithyroidectomy, the reliability or the accuracy of TG is probably not that accurate, and you need to supplement it with an ultrasound. So perhaps a little bit of a more economic burden to the patient and a hanging sword over his head. Oh my God, doctor, am I going to find the tumor on this scan? So it's not surprising that if they know that it's a malignant nodule, majority physicians would want to do a total thyroidectomy. Again, a paper which looked at unifocal non-invasive papillary thyroid cancer after the ATA 2015 guidelines, and Abhishek showed you a splurge of hemithyroidectomy is being done. Another paper published as recent as last year, 60% still want to do a total thyroidectomy. 40% would do a completion had there been any surprises on histology. And I must confess, it's not just the audience. Even I feel like this gentleman at the end of these past 20 minutes. I love the arguments on either side, but can you just please tell me what to do? Well, who tells us that? If you're waiting for level 1 evidence to tell us that, you're going to have to wait 30 years and follow up more than 10,000 patients. So that's not happening. The guidelines are equally diametrically divided. The European and the American tend to be more conservative. The Japanese would do a 5-centimeter thyroid cancer with a Hemi. Institutional policies, well, you pick up a paper, and depending upon the first author and the year of publication, the same institute can give you absolutely contradictory data. So in this era of personalized medicine, we include patient preference. And this is a typical conclusion to every such case-based panel discussion, where the expert will then say, oh, I'll speak to the patient and explain to her all the pros and cons of either approach and tell her about the biology of the disease, and let's see what she's comfortable with. Well, let's see what she's comfortable with. This was a JAMA paper where they spoke to 500 thyroid nodule patients. They gave a balanced third-person counseling on the risks and benefits of both a Hemi and a total thyroidectomy, and a patient was more likely to choose total thyroidectomy 3 times over if there was even a mention of a potential malignant nature in her thyroid. And that's why I feel total thyroidectomy ticks all the boxes. Equivocal survival, better at recurrences, no morbidity of a completion operation, a reasonably safe operation to begin with, allows a correct application of RAI and a follow-up with thyroglobulin, and most importantly, has withstood the test of time. Well, this was my job that the organizers have given me. I don't know why they decided to do this to me, that I had to speak on a lesser popular motion and against a worthy opponent. But if I was able to do this, I'll be happy at the end of the day. Thank you.
That's very nice. Very nicely put and ended. Well done, both of you. I remember when we were in the school and when we had an argument, and we had a big argument on the field, the person we went to was the headmaster. And we asked the headmaster, he says so and so, I say and so, who is right? And today's arguments will be settled in a very nice way, in a more experienced way, by none other than Professor Ashok Shah. Let me introduce, in case we have missed out on introducing him earlier, see, a man with a great empathy for everything he does. And not only just a great sense of humor, but behind the humor there is warmth. There's a humor is not attacking, but is pleasing. His knowledge is profound. And you open up any book on thyroid, unless there is a chapter which is done by him, the book is not complete. He had been moving, he had been the Secretary General of the IAOHNS, and I would say that I look up to him for everything in thyroid, and probably the audience is extremely, extremely lucky to have him today, despite of all the schedules he might be having, to spare time for us on their Saturday morning, which is like a weekend for them, that's a holiday, and be available to us to guide us and be a judge. Over to you, Professor Ashok Shah. Right or left?
Thank you very much. There is, you know, we always say in medicine, there are two right answers. You have to choose what is right for you and your patient. So I'm going to give a summation in a short period of time. Let me see. I need to go back here. Let me go to stop share and 1 second. Hopefully I'll be able to do this now.
Yeah.
Okay. Okay. So when a thing ceases to be a subject of controversy, it ceases to be a subject of interest. And that's why I said we have two right answers. When you leave New York and go to Mumbai, you can take Air India, you can take United Airlines. How do we make a decision? What is the best time? Who gives the best food? That is something that I enjoy very much. So you decide upon that. Again, these are the two right answers. You have to decide what is good for you, your institution, and your practice and your patient. And I think both the speakers did a fantastic job arguing for and against. What we should do for the next debate is switch the speakers. And let's see how they will argue. And I can assure you, they will argue again passionately for the same subject. So why is there a debate? Why are we arguing? The results are good in both the procedures. If there was a huge outcome difference, nobody will ever argue. Because the results are the same, we love to argue. Most of the patients belong to the low risk group with excellent prognosis. And as both the speakers said, the role of adjuvant therapy, which is radioactive iodine, is totally undefined in low risk patients. We're not talking about the high risk or the high risk intermediate groups. The one thing we do need to realize, and both the speakers alluded to, is complications increase with extent of surgery. I think we need to keep that in mind. And the last thing is there are no prospective trials, as Diti said. And what is important in the management of thyroid cancer, I like to call this a unique human neoplasm. Don't compare thyroid cancer to pancreatic cancer. This is a friendly cancer. It's like your neighbor who bothers you a little bit, but you still go to his house for dinner. Nothing wrong in that. So I think we need to realize the biology of thyroid cancer and apply that biology to the low-risk patients with thyroid cancer. My favorite slide, you probably have seen this. Whatever the two speakers spoke for the last 20 minutes, only 20% of us were going to remember 20% of what they said 20 minutes after the lecture. Now, this is very interesting. we need to develop a philosophy of being cost-effective, evidence-based, use or optimize the resource utilization, and avoid unnecessary treatment. The entire focus of management of thyroid tumors, thyroid nodules, thyroid cancer is avoid unnecessary treatment or over-treatment. And the reason is the over-treatment or unnecessary treatment has high risks of both medical and surgical complications. A poor patient from a village in India may not be able to get to thyroid medication. And she may be off thyroid medication for 3 months till she comes to Nagpur and gets the medication, something that we need to keep in mind. And the next thing is the only thing you need in your career is one young woman with permanent hypoparathyroidism. And I must give credit to Dr. Kapre for being so bold in a national meeting to say he lost a patient with permanent hypoparathyroidism. It has happened to all of us, but we have not come out in the national scene and argue about it or present that data. Now, I have shown this slide several times. What is important, and I think we at Memorial introduced the intermediate risk group, which is very important. Before that, there were only 2 risk groups, the low and the high. If you look at the risk group analysis, and you can see here, the survival is the same in the low risk group. It is poor in the high risk group. Thyroid cancer is a good cancer if you belong to low risk group. It is not a good cancer if you belong to high risk group. And our responsibility is to spend more time on high risk group. But there we don't have debate. We know exactly what to do. And that's why we love the low risk group, because we can debate with our friends and then take them out for dinner. Now, this is the summary slide. Selection of therapy. In the low risk group, you can do a lobectomy, the outcome is the same. The high risk group, be very aggressive, use newer therapies, which is the focus of our future direction or future research. And the intermediate risk group is very important. Be discreet, be aggressive. And what we need to learn in thyroid surgery is what is the true intermediate risk group, where the benefit can be obtained with total thyroidectomy and in selected patients with radioactive iodine. The next 2 slides are made specifically for this symposium. And I want you to spend little time trying to understand what is the responsibility of a surgeon when he sees a patient with a thyroid nodule preoperatively. It should be less than 4 centimeters. Now, the ATA used the number 4 centimeters, but realize from 2 centimeters to 4 centimeters, there is a higher risk of nodal disease. There is a higher risk of minor extrathyroidal extension, and we need to put this in perspective. Any surgeon who is going to take a patient to the operating room for lobectomy must be prepared to do a total thyroidectomy if necessary. And that's the judgment he has to use, and the patient has to comply with that. There should be no adverse clinical features, fixed and hard mass. And I think this is what we learned in the last few years. It should not be irregular. The ultrasound will tell us those are more aggressive tumors or something that you feel clinically palpable hard nodule. There should be no suspicious nodules on the other side. And this is very important. You will see many publications showing 1 centimeter nodule on the other side. That patient needs total thyroidectomy. There is no doubt about that. So the macro cancer on the other side is not an argument. That is a straightforward case for total thyroidectomy. There should be no suspicious lymph nodes either in the central compartment or lateral compartment, which you can get very good information with a good ultrasound. And I would add one more, if necessary, get a CAT scan. And I think we have undermined the CAT scan so much in clinical practice of thyroid. You are large nodule, you are concerned, you are worried, get a CAT scan. CAT scan is very easy for the surgeon to interpret and get some more information, irregularity of the nodule. What do you see on the other side? The extrathyroidal extension. All this information you can get very well with a CAT scan. And again, what is important is what does your endocrinologist like? What does your institution like? What do you like? And the last thing, the completeness of the quadrangle is, what does the patient want, his family wants, his neighbor wants, his gardener wants, and his mailman wants. I think that's very important to realize when we make these decisions. What am I going to do in the operating room? Always consent for total thyroidectomy. If you find adverse features of multiple lymph nodes, not one or two lymph nodes, one or two lymph nodes is almost a given in thyroid cancer, but there is a glob of lymph nodes. The lymph nodes show larger tumor, extranodal extension. If there is a gross extrathyroidal extension, my personal practice in thyroid nodule is to take the inner strap muscle, the sternothyroid, not the sternohyoid. You pull the sternohyoid, but take the sternothyroid. So when the final report comes, minor extrathyroidal extension, I can say proudly, I have done a satisfactory and a good oncologic procedure, something that many surgeons don't practice. I always like to look at the paratracheal lymph nodes and the Delphian nodes. Our incidence of Delphian node positivity was 25%, number one. And number two, those patients who had Delphian node positive at the time of surgery had higher incidence of paratracheal node disease. If there are multiple suspicious lymph nodes, more than 5, 6, 7, go ahead and do total thyroidectomy same time. So these two slides are important for a surgeon to identify who are the right candidates for lobectomy, who are the right candidates for total thyroidectomy. Now, I wrote this paper exactly 30 years back. Niti was not born at that time. There was just a thought of Niti at that time. And you can see here, even 30 years back, I wrote about extent of thyroidectomy, depending upon the needle biopsy, the preoperative findings, the risk group stratification, and which are the high risk group analysis of the thyroid, both pre-op and intra-op. Nothing has changed over the last 30 years. The same debate we have been arguing for the last 40 years. Now, this is one of my paper, which is I felt very good about writing this paper because we looked at our own data, lobectomy versus total thyroidectomy. Take a look here. The survival curve is the same, 99 to 100%. We have a saying at Memorial, if you walk on the streets of New York City for 20 years, your survival is 98%. If you have thyroid cancer, your survival is 99 to 100%. A New York cabbie is more likely to kill you rather than the thyroid cancer. And I think this is very true when it comes to low-risk thyroid cancer. And you all saw this, and Abhishek, thank you for showing the slide with my name. Actually, that came from Tim Thomas. An operation not worth doing is not worth doing well. Remember, we always debate in thyroid, lobectomy versus total thyroidectomy. You know why we debate? It is fun. It is not a science. It is the philosophy. It's a dogma with which we live. We don't debate in total laryngectomy. We don't debate about total glossectomy. We don't debate about total colectomy. We just love to debate about thyroid. This is our data. I don't want to show you a lot of data, but our own experience with lobectomy and total thyroidectomy, everything is the same. There is no statistical difference. Local recurrence, nodal recurrence, distant disease, overall survival, same. Okay. And again, I think both Niti and Abhishek showed this. This is the paper. And the only reason I'm showing you is this. Before this paper, the same data was analyzed by Carl Bilimoria, who was the prime person behind the 2009 guidelines. And these are the 2015 guidelines, the same data analyzed by different group of people. Again, what you read in the book is not what is reality. What is reality is what comes from your heart, what comes from your experience and your personal philosophy. And I can't live without showing this slide. Let the punishment fit the crime. And this is very important when it comes to thyroid cancer. Aggressive tumor, be aggressive. Low risk tumor, don't look at the tumor itself. Look at the outcome, what the patient wants, what the complication rate, and don't look at the complication rate published in the book. That is not important. Look at the complications from your heart. That's more important. I hope in last 5 minutes I have not confused you. But if I have confused you, I will take the greatest credit. Because the job in thyroid is to keep this pot boiling. We need to continue to have the debate. And I think we have almost ended up the debate of extent of thyroidectomy. And now we are debating about prophylactic neck dissection. That's the debate for the day. Keep in mind, total thyroidectomy is one-way traffic. You cannot come back. Lobectomy is a two-way traffic. You can make a U-turn. You can make a U-turn on the same lane if police is not there and come back and join the crowd. You can always take it out, but you can't put it back. I think this is something that we need to realize. Yes, there is a second operation if needed, but the number of people who really need second operation is infinitely small. And even though Niti showed our data, I know that was the data that we reviewed from a different angle, but our overall incidence of requiring completion thyroidectomy is less than 10% if you adhere to the principles of understanding low-risk thyroid cancer. And I want to show this slide because we have seen this slide many times, but I just want to show you the statement, the commonplace clinical problems in surgery, like lobectomy, total thyroidectomy, prophylactic neck dissection, are approached in a diametrically opposite ways. Niti showed one slide, last slide, which was this way or that way. You come to the same point. United or Air India, you reach Bombay the same time, the same way, same duration. What we do is we read the same books, we read the same literature, but most important, we interpret available information differently based on unique personal experience, vision, and the most important thing in surgery is the surgical prejudice, or better word, surgical ego or surgical dogma. It is that dogma which is important to further the science. So yes, dogma is not good, but in surgery, dogma is good, but somebody can challenge you. If there was nobody to challenge, we wouldn't make progress in surgery. Thank you very much.
Very well said, very well, perfectly said. I think you have not only summed up, but probably done a job of putting the debate to an end, and rightly said, if this debate is over, the next one will be prophylactic neck dissection. Go on. So maybe Niti and we should start getting ready for the next debate to do a prophylactic or not do. There's one more left out. Prophylactic thyroidectomy for medullary cancer. That debate might be something we'll boiling again before we finish our careers. But well done, sir. Well done as usual. Excellent. Thank you very much for putting a perfect perspective for the younger guys. Because we have in the audience not only the oncologists, but general ENT surgeons or even occasional surgeons who would be benefited enormously by the last slides where he has put everything into right perspective. I would like to share with you a little thing which my boss always said when I was in my surgical training in Nagpur, and that was, in the best interest of the patient is the phrase used by surgeons to pursue their own interest.
Yes.
I think often we say, oh, my patient is so poor that in the best interest, I should do this. I think, put your hand on your heart and say, is that really true? Maybe not. Anyway, we get back to the next agenda that we have, and that is to bring some of the topics. I know we are running late and short of time. Vijay, are you worried? Can we have few cases at least on the panel?
Yeah, no problem. Please go ahead.
Okay. So we start doing a panel, and this panel, as I said, will be focusing on problems or the difficult areas which most of the general ENT guys or younger surgeon face. So may I now therefore introduce the panelist, which is, you already met Professor Ashok Shah, and I have amply admired him all my life since I come back from UK. I missed him in my short stint at the US, but ever since I come back, he had been an enormous inspiration and a guidance. You are lucky to have him on the screen. You already met Professor Neil Tolley. Neil Tolley is a professor of thyroid surgery in London and at St. Mary's Hospital, which is a trust hospital. And I have a really little personal favor for him, or personal appreciation, soft spot, because we both know Dudley, Birmingham. I was in Wolverhampton, he is in Budley, about 10 kilometers apart. Anyway, the other people are none other than Jyoti. She was silent so far. Where is she? I can't see her on the screen. Jyoti, please.
I'm here.
You're there. Because Jyoti had seen thyroid inside out. She was a very regular, when we were very primitive thyroid facilities there. She has worked there without a cautery. And may I share with you, Professor Shah, you would like to know this because you know Jyoti, but some of the things about Jyoti, people should know. One time she asked me, Madan, if it's okay if I bring some excess baggage, do you have friends at the airport to organize that? And I said, Jyoti, sure, Nagpur is a small place. We can do that. You know what the excess baggage was? Blankets. She brought blankets for the patient. I was touched. And she had done many things. I can tell you on and on. The debate will be over. So I stop there. The next is, of course, Prathamesh. Prathamesh, we are very proud of him. He is our sort of next generation limelight. And we look up to him to take our Indian academy and particularly the head and neck oncology to higher heights. He comes from Tata Memorial. He's a professor over there. Deven Maure has expressed his inability because he's not getting adequate signal where he's working. He works at one of the district places as professor of ENT, Chandrapur. Unfortunately, he can't be on the screen. I can't see Professor Bal here. Are you there, sir? Not joined? Anyway, if he's on the screen...
he's there. Sorry to interrupt. He's there. He has to
I am very much there, sir.
I can't see you. I can't hear you. Nice. Lovely to see you. But you don't have the usual fanfare like behind you. There is no Bahama or Panama behind you. It's a normal homely screen behind you.
That I removed. A lot of things.
Thank you very much. And having introduced Professor Bal is one of the very, very scientific person in the endocrinology, particularly radionuclide. And I have a greatest regard because he speaks from experience, he speaks from statistics that he has his own, and he has the courage to stand up and face anybody with conviction when he is on the right side. So he is not an easy option to push over. And we want people like Prathamesh, people like Bal to take us to higher heights because we are looking up to them to take India to a newer future under the guidance of, I'm sure Professor Shah will be not behind, to put these guys on the right track for the future. So with this much of my request to Professor Shah and introduction of my panelists, let me start off with my first question. And I admit, being a background tribal, I don't mind to be naked and stripped off in front of all of you. But when I went and faced my patient, I don't want to look like this. I want to look more sophisticated, like a knowledgeable person. Now, as this famous picture, we are going to draw wisdom from Professor Shah, Professor Tolley, and introduce all of them. And in fact, the order which I began with was such a tall one because I do not know how many accomplished oncology are on the audience, but I'm sure as much as there are learned guys, there are learners on the audience also. So with the faculty so learned, I'm trying to bring them down a little bit one notch to the level where everybody can meet and talk. As far as I am concerned, I've learned equally from professors and the theatre staff nurses. So for you guys, you are lucky. You have got best of the best. Now, desert island, that's my first question to all my panelists. We have got plethora of this. And in my early days, FNSE was supposedly a desert island or the first test to go for. Then somebody said, no, it's not that, it's TSH. Oh, no, it's not both of them, it's ultrasound. So I want the panelists one by one to come on and say what is their desert island test in a patient who comes to you with something like a straightforward lump in the thyroid. Can I begin with Professor Shah?
Yeah, thank you very much. Your comments are very, very educational to all of us, so I appreciate that. And your commitment is well recognized around the world. So this patient presents with a nice right thyroid nodule, probably 3.5 centimeter, well defined. We don't know what it is going to be. Just looking at it, you can, in the olden days, we didn't have any investigations. We had only hands and the brain. We don't use those anymore. We go for ultrasound. And I think that is very appropriate. What am I going to look for the ultrasound? What is the size of the nodule? What is the location of the nodule? Number two, very important, and we forget many times, even in the United States, is to look for the lymph nodes. I think lymph node mapping is very important. Anybody who is going for the neck ultrasound or thyroid ultrasound needs to divide it between the thyroid and the lymph nodes. And sometimes they don't do the lymph nodes in the United States because there is a different charge, different code. And the last thing you need to see is the opposite lobe. What's the status of the opposite lobe? Can we add a CAT scan? I think I love it because I can see it better. I know how to interpret. I don't like MRI because I don't think it helps me much to make any decisions. And the radioactive iodine scan or radionuclide scan, which used to be the olden time, go hot, cold, boiling hot, lukewarm. I don't think we have used that for a long time. The only time I would use a radionuclide scan is when the TSH is below 0.001 and you think this is hyper toxic nodule, then I would use it. But that is pretty rare in our clinical experience. So the imaging, very simple, ultrasonography and CT scan if needed.
So would I take it that you will be advising sonography as your desert island test? If you do only one, would you do a sonography? Is that your choice?
Yes.
Correct?
I think I would do a sonography, but in this case, I think I would go both sonography or CAT scan. I don't think it makes much difference. It is going to give the same information. The reason I use the sonography is majority of the thyroid nodules are non-palpable. And that's where the sonography is very helpful. This one is a very obvious big nodule. You made a decision when she walked in your office, she needs surgery. She's a young woman. She's not going to live with this for the rest of her life. So those are the clinical judgment and clinical decisions. Is the sonography a must in this case? Probably for the lymph nodes. Otherwise, it is not necessary.
Right. I think, Jyoti, you go next. You are a professor, hardcore professor for years. I forgot to mention she is a professor emeritus at KM. So, Jyoti, if this patient walks in, what is the first test you will tell your juniors, houseman, registrar to do?
So do I repeat what Dr. Shah said? Because the first line of investigation basically is ultrasonography, available everywhere, cheaper, gives you a lot of information. If you divide your findings into thyroid's classification, you had a fairly good amount of suspicious if it is malignant or not. For example, if it is hypoechoic, taller than wider, irregular margins, increased vascularity and lymph nodes, this is a clear-cut case of thyroid malignancy. So what I'm saying is, more than what Dr. Shah said, this gives you an idea from the, and then you put the points, and then the score is determined, thyroid score, and it divides the nodule into 5 categories. The first 3 categories are like benign or equivocal, but as the category goes higher, 4 or 5, you are definitely dealing with cancer. So if the sonography gives you so much of information, I think not only you should do it, but your radiologist should give you enough information. And if he is not doing, you should take him out to a meeting where these thyroids are discussed in detail. So what I'm trying to say is, majority of time, the radiologist does not give information, and the clinician is satisfied with the information he has given, this much length, this much breadth, this, that, and the other. It should be clear-cut 5 varieties of information: hypoechogenicity, irregular margin, taller than wider, peripheral halo, and lymph nodes.
Jyoti, on this slide, I want to just ask everybody, that is it a unanimous panel saying that the first thing that they will do for this patient is ultrasound? Nobody has mentioned FNAC yet, or find FNAB as they call it.
No, Madan, it comes after sonography because lot of nodules are cystic. And if you go and do the sonography from cystic nodule, you are likely to get negative for malignancy. So if you have a sonography report, your pathologist knows where he has to put a needle.
Right.
And that is the reason FNAC should be next.
Rathamesh, anything else?
Sir, I think it is very aptly described in great detail. Ultrasound should be the modality of choice, the first investigation, because it gives you structural knowledge. It gives you information about the nodule, and you'll be able to discuss with the patient what is to be done further. Normally, what we would also advise is based on your rapport with the radiologist. If they are doing the ultrasound, if they find something very suspicious, they should put in an FNAC at the same time. So this should be done alongside, as Dr. Davolkar rightly mentioned. You need more information, and today ultrasound-guided FNAC should be the way ahead. No longer we should be practicing FNAC.
I wanted to make this say, thanks, Prathamesh.
Madan.
Point over, because in practice in places which are across the country, the first test that anybody would do, put a needle into it. And FNAC was a thing which everybody did about, I think, a decade ago. But now we are wiser that we put ultrasonography first. But what about this? Anybody for this test? Anybody wanting to do even a simple radiograph anymore, or that's gone?
No, we
see, Madan, there will always be a tracheal shift in a large goiters and a narrowing of the airway. So the X-ray neck or X-ray definitely gives you the information to the anesthetist. And I have seen in KEM also, the anesthetist would like to, the moment they see a large nodule, they will advise that let's see the airway and where is the trachea shifted. But today, with so much of advancement of anesthesia, I don't think, because the moment you push the thyroid, which is large, into the midline when they are intubating, the trachea is straight. The trachea is straight. So my question is,
I just wanted to bring this
information,
which you have aptly said, that it is an anesthetist who will always ask you for an X-ray chest. It's not a bad test to do, and your patient will always benefit from doing something simpler. But I think this is slightly gone on the hindsight, and no more the test of the choice. And everybody has spoken so well about ultrasonography. So I would like to probably speak, but I can't finish any place.
Can I put a word?
Of course, sir. Go on.
Yes, there is a lot of discussion, and ATA guideline describes this thyroid and everything. Even in FNA, we have got all this from 1 to 5, and then we know this is definitely. So we have moved from a yes/no grayscale. We have now put them probabilistic. What ultrasound information we practically expect in a clinic is to say whether solid or cystic. If it is solid, patient goes for FNA. If it is cystic and it has got some solid component, you can directly direct the FNA from that. And the second important thing where we get information is regarding the nodes. And as you know, in the central compartment, the ultrasound is blind to the central compartment. That's why ATA has recommended CT scan for planning for a curative surgery intent. So if you are doing a CT scan, what is the need of doing X-ray? CT scan will come much more.
For the sake of completion at the beginning.
Yes,
this I love to show, because this was tubercular lymph node sitting in the neck, and this was, you can see the yellow paper. I don't know if Professor remembers that in good old days the X-rays came in a yellow paper, and this is one of those yellow papers where the X-rays were done, and the node was aspirated, tuberculosis, and surgery avoided. But this is what everybody has talked about. So I'll skip this slide. I was trying to put this across.
So that is what exactly I said.
Except the academic institution, if you say 90% of the time when patient comes to me,
report, because
hardly any place I have given like that.
Along the
Hello?
I think, have we lost this?
No.
Yeah, so Madan, exactly this is what we discussed.
Yeah, this is what we see in
So now
academic
the next
institutions,
question I
but not in the real practice in India. What the ATA has recommended, all these FNS, even pathology report has every line, and we get one line saying papillary thyroid carcinoma.
When would you ask for a sonography guided FNC?
Sonography?
Guided FNC.
US.
See, if your thyroid swelling is largely cystic on your palpation, then you have to look for a solid component to that on sonography, and then you can do the sonography guided biopsy from that solid component. Your chances of getting a right diagnosis is much more higher. But you cannot say, okay, in these circumstances I'll do sonography guided biopsy, or if your first report is negative on FNST and you are still suspecting, it is cancer. Madan, I got a clear answer for you. If your first report is negative on FNST and you are suspecting, your suspicion for malignancy is very, very high, then you should do the FNST by USG guidance.
Yeah. You see, the other issue comes.
That is a clear-cut situation to do FNST guided biopsy. USG guided biopsy.
Yeah. The other issue comes, Jyoti, is when we are dealing in a place like peripheral multinodular goiter, big goiters. Where would you put needle on multiple sites? One side? How many needles do you put in?
Absolutely. That is what. So that if you are doing a FNST guided biopsy in a multinodular goiter, then your USG guided biopsy, then the swelling, the nodule which is highly suspicious on a thyroid, that should be biopsized. Though it doesn't make a difference because you are going to do anyway total thyroidectomy, but for better counseling with the patient and also decision to do the neck dissection will be preoperatively if you have one of the nodule positive for cancer. So in a multinodular cancer, if it is a surgical case, anyway you are going to do a total thyroid. But if you have a preoperative diagnosis of one of the nodule as a malignant nodule, then your counseling is better, your planning of the surgery is better preoperatively.
Okay, thanks, Jyoti. Now I've come to the second law. Is the reason why I'm thrashing out this investigation. This is what the practice in distal places, practice in municipal places, that people unnecessarily investigate sometimes. And you have a patient who comes to you with a scan already done, or a patient with a radionuclide scan done prior to it comes to you for a nodule. So what hot and cold nodules were talked about in the past, and Professor Shah rightly put it. Hot nodule, warm nodule, very hot nodule, cold nodule. I think we'll come to that in a short while, but I want to take a view from Neil. What are the indications where we specifically ask for
a CT scan or an MRI?
Madan, can I take this question? Madan, can I take this question? Madan? Yeah. So basically, CT scan is indicated. CT scan is indicated for swellings more than 4 to 5 centimeters, hard to the palpation, partly or fully fixed to the surrounding tissue, having lymph nodes, and patient having a stridor. These are the clear-cut indication for CT scan right away. In a less indicated situation, suppose if you have lymph nodes and the central compartment is not visible on sonography, which we know. Sonography cannot tell you the status of the central compartment. So if you have a CT scan added to the USG, you will have a clear-cut indication or clear-cut idea about the central compartment. So basically, CT scan is indicated to give more information about the involvement of the peripheral, involvement of the lymph nodes, central and lateral, see the fixity, see the involvement of the larynx if patient is on stridor, see the involvement of the extrathyroid tissues, and basically to have a better understanding about the preoperative planning and counseling
Jyoti.
to the patient.
Now, just last one question for Neil again, because I'm sure that you have a lot of patients who have got a neck scan done for completely other reasons than the thyroid. You come up with this incident
all the time. Very, very common incident.
How do you deal with them in clinical scenario? Incidental mass. We're not going to chase it further because we have a lot of questions to come. We have cases to take. I just wonder how often you face this situation.
Very commonly. So people have had MRIs of the neck. We see nodules within the thyroid if they've had investigations of the carotid arteries. Again, pathology is found in the thyroid, but even if it's nodularity discovered on CT or MRI, we would still request an ultrasound scan. Can I just, for the trainees, madam, just put a hand up for the old techniques of inspection, you know, palpation, auscultation, reflection, because the very first slide that you showed with your desert island, you know, must, well, if you're on a desert island, we don't have laboratory investigations. And I think it's very important to still just look at the patient, look at the age. That's a slim neck. It's a young female. Sometimes it's very obvious if it's just a single nodule or it's part of a multinodular pathology. Examine the lateral compartment of the neck. Can you get below the thyroid gland? And you've actually got to take some cognizance as to whether they're euthyroid or hypothyroid or hyperthyroid. So I think the minimal blood investigations should be thyroid function tests. I think thyroid globulin has no role whatsoever in the preoperative assessment of a thyroid nodule, and thyroid antibodies it's limited to.
Yeah.
Neil,
Right.
I mean, I don't know about your anesthetic.
For the sake of time, I'll just skip through a few of my slides, which was what happened. Yeah, I mean, about this slide, Professor Shah has very aptly said, and I'm sure he will be having a smile because this is the slide I put up here. This is an old slide, but I don't think beyond this slide, 2003, anybody is doing as a frontline investigation for thyroid nodules. So we skip that. We will come to PET scan little later because we have a case to discuss. So we'll skip that also because there is a little short time. So can we just move on to this is little important. Let's wait a little while. FNAC. Often we get a one-liner, Bethesda 2, Bethesda 4, one-liner report. Professor Shah is smiling. Sir, please, go ahead. Your views on FNAC.
You know, I must give credit to the British group for developing the Thai classification. And it took a long time to use that similar philosophy in the United States. Started about 12 years back with the big conference in the NIH, and that's why the term came Bethesda system. I think it is a good system. It's a standardization of the reporting. Anytime we have a classification, the idea is to standardize. And I think the problem comes when it is a Bethesda 3 and 4. What do we do about it? Because again, I must say, that's where the clinical judgment, the clinical findings, how does the thyroid nodule look? What is the age of the patient? What is the size? What is the irregularity? Those are important parameters. And the TI-RADS have been quite helpful. If you use the TI-RADS, your clinical judgment, I don't think it makes any difference whether it is Bethesda 3, 4, you have made the clinical decision. This is where I just want to add the role of molecular markers. In an effort to find which nodule should go to the operating room so that we don't do too many unnecessary benign operations, and impact was made with the use of molecular markers. I must add 2 points. And I said it before, if you use your good clinical judgment, good ultrasound and imaging, I'm not sure in my heart that the molecular markers are going to change the decision making on that patient. The case you showed, we know that patient is going to go to the operating room. The molecular markers is not going to change. When does it change? It changes if the BRAF is positive or TERT is positive, then you know it is thyroid cancer, no matter what the needle biopsy shows. There are two issues about the molecular markers: prohibitively expensive. The average price in the United States is $5,000 to $6,000. I did some calculations, and in our indeterminate needle biopsies, if you do molecular markers all around the United States, we are going to spend $1 billion per year. Too much. And does it add much to the decision making? Probably not. Why do we do it? Because in some patients we don't want to operate, or the patient does not want operation and wants to be sure this is a benign nodule, you do the molecular testing, Afirma or Thyroseq. If they are negative, it is a good negative test. It is not the best positive test. So, but also we have to realize in other parts of the world, molecular markers are not available. I would conclude by saying the molecular markers have limited role in the management, not evaluation, management of thyroid nodules.
Thank you very much. But my problem is, look at this particular type of report that comes. We all know that Bethesda is a language. Bethesda is a way of describing things. People don't read the report. They only look at the first line. But look at what comes in most of the district places, the report, the line on the right-hand side of the screen. They keep on giving the average malignancies in the column. Are you bothered about this way of reporting, anyone? Or are you happy about it?
I think that is a very good question. That's $1 million question, which probably should be discussed in a national advisory group. If you look at, actually, I don't know if you have seen many Bethesda, the molecular marker reports. It's a 6-page report with like 25 references, total confusing. Even today, it is confusing to me to interpret that report. The problem is, this is the way they have decided to report. Does it help? I think it confuses the patients more. And that's why they would say, okay, my Bethesda is 4, so I got 30% risk of malignancy, I want operation. If the nodule is below 1 centimeter, it doesn't matter what the Bethesda is. So yes, I think this is probably going to be the future in the decision making and reporting of all these systems.
Rathamesh?
So you had put up that first slide, and when you put up that slide, Dr. Shah said this patient has walked into the clinic knowing she needs a thyroidectomy. So it doesn't really matter whether your ultrasonology with your FNAC is going to tell me it's a Bethesda 3 or a 4. Patient is going to say, I want that surgery. So like Dr. Shah rightly mentioned, if it is a lab nodule less than 1 centimeter, that's the point where you're really trying to understand whether this patient should undergo surgery. Clinically obvious large nodule, more than 1 centimeter, a patient has come in for surgery. So it doesn't really matter whether it's a Bethesda 3 or 4, you're going to offer surgery. If you tell the patient that there is cancer in it, the patient is going to say, please take it out. So Niti rightly mentioned in one of the slides that if the patient was aware that there was a possibility of a cancer, the patient is not going to be satisfied by you telling that, let's observe, after 3 months, I'll do an ultrasound, I'll do a repeat FNAC. A Bethesda 3 would suggest that you would want to repeat an FNAC to be sure that you can avoid doing the surgery in those 70% of patients.
Rathamesh, my question is that most of these district places, when they give a Bethesda report, they add this addendum to it with the risk stratified on the right-hand side of the report. And most of when you read it, does it worry you? That's my question.
As Dr. Shah mentioned, this was the Bethesda group that actually had a group of pathologists sit around and then discuss at the top of the head what would be their possibility of malignancy. There is no documentation with large databases which have looked at this. We looked at our own data. Our pathologists report Bethesda 3 and Bethesda 4. And finally, when we operate them, how many of them turn out to be cancer? We were surprised that when we looked at the Bethesda 4, more than 70% of those patients had malignancy. So here, when you look at the risk of malignancy, it's about 15 to 30%. So where does this stand? It should be, like Dr. Shah said, there should be a national consensus, there should be institutional review of your Bethesda, and then you make a decision. The next time your patient comes to you, your pathologist reports Bethesda 4, you are then sure what's your risk of malignancy.
Absolutely. This is what we are doing. We are sort of, in our center, we are trying to do our own scales and try to come up with our own possibility of malignancy rather than getting carried away by somebody saying that, oh, this means so much so. So I think all of us should get together and put our brains together and maybe have a statistics of your own institution with your own pathologist. Because what Bethesda system tells you may not necessarily be applicable. Dr. Ravi, I don't know whether you know Dr. Ravi, who is upstairs here. We are working on this, and maybe, hopefully, there will be some scheme for our own institution, like Professor Shah said, that all the knowledge that you read in the books, when that translates into practice, it has to be your own. Anyway,
Madan, can I make a comment?
Because this is not right. I'm going to just run through this case and come to the last bit on this case. This is a straightforward, what looks like a thyroglossal cyst. She underwent surgery, cyst shunt operation, fine, so far so good. Now comes the problem, that the final twist in the tail was that the pathologist says that she had a malignancy. What would you now do? Who wants to go? Neil, you want to go?
Yes. What's the ultrasound scan of the thyroid show? Does it show any pathology? Any notes?
Ultrasound of the rest of the normal.
Okay. This is a young child. I think the patient's had sufficient treatment.
No, she's 17.
Yeah, well,
I think she can be left alone.
Yeah, that's it. That's sufficient treatment, I think. Cistrons.
Is that the consensus, Prathamesh? Would you leave her alone now?
Yes.
I would also agree with Professor Neil Tolley that this patient is to be categorized as a low risk. So you do a risk stratification. This patient has a low risk. The thyroid is absolutely normal. There are no lymph nodes. There is no indication for doing any further treatment in this patient.
See, I wish there was Deven Mahure on this particular line, because we had a spate of these kind of things, 3 or 4 in a row, and we went to the literature and there is a divided opinion. Somebody says this is a different organ and this is a different system, so it doesn't belong to thyroid. So if it is removed, that's the end of the story. Some people would say, no, go by the standard. If it was so and so centimeter by so and so centimeter, Professor Shah, would you say, what would you do? Would you accept to leave it alone? This is 2.4 centimeter.
Yeah, we wrote a paper on this about maybe 20 years back. Snehal, myself, and a couple of other people, and Helmut Geppert wrote an editorial on that in the Head Neck. I think Neil asked a very good question. What's the remaining thyroid looks like? If it looks like a normal thyroid, it's like you had done a lobectomy. Yes, it is away from the thyroid, but this is a low-risk cancer. The only 2 factors in this case is she's 17. So you want to be absolutely sure that the lymph nodes are not involved. Unlikely, because this is an encapsulated disease, but you have specifically written here, there are some level 2 nodes. Level 2 nodes are very common in young people. I would keep them monitored. If they get bigger or there is some radiological feature, I would do a needle biopsy of that node. Otherwise, this lady in my books is cured of this cancer. Just monitor the ultrasound once a year and thyroid functions.
So ultrasonography monitoring is all that recommended. What about the scans? Would you not do a scan?
Which scan?
Dr. Bal, I'm just asking you a question.
No scan is required. But this is a 17-year-old girl with a T2 tumor and pori nodes. Yes, clearly observation, very maybe first to once in a year for 5 years, and subsequently if she doesn't have any recurrence, maybe consider as. But
thank you very much. Now we come to the real surgical side now. Vijay, please tell us, because we are running over.
Okay. Dad at HDFC 0.
Well, if he's asleep, we'll carry on. This is a 28-year-old female with recent onset of slow-growing right-sided thyroid swelling, 3 by 2 centimeter, follicular neoplasm, euthyroid, ultrasound, TARATS 4A, that is a solid nodule, well-defined margin, no capsular invasion, no calcification, heterogeneous, hypoepic, normal vascularity, opposite lobe normal, and no lymphadenopathy. What are you going to do now? What recommendations are there? Can we start from Prathamesh? Your choice of surgery for her?
So you don't have any possibility that this is a malignancy, but your TREDS is 4A. So
Yeah.
would you then label this? Your FNAC is not there for this patient.
Follicular neoplasm.
Follicular neoplasm. So I would discuss with the patient that there is a possibility that you might be harboring malignancy, but going by the ultrasound, the hypoechogenicity is the only characteristic feature apart from the solid nodule which might suggest a malignancy. So I would do a hemithyroidectomy. If I had the facility of frozen section, I would ask the pathologist whether they would be comfortable. In TMH, in Tata Hospital, pathologists would not do a frozen section on this because they would say, let's wait for the final pathology. So I would do a hemithyroidectomy and then look at the pathology report, rush for it. If there was, like Dr. Shah mentioned, if there was other features intraoperative, like involvement of the strap muscles or possibility of any lymph node.
How many of you would actually take a consent for total? Would you say that on the table, if I am doubtful, if I find opposite lobe not so good or the tumor not so good, I may do a total? Would you take that consent beforehand? How many of you do that?
But Madan, you have got a maximum information on sonography that the opposite lobe is normal, no lymphadenopathy, plus it's a unilateral nodule, and histopathology is like follicular. So chances of doing total are very, very less in this patient.
Professor Shah,
so consent, for the sake of consent, you can take it because
I
Indian
would probably,
patients,
if required, go for total.
I think this patient will be very well served with a lobectomy, but we always like to add that point, and that is extremely rare in a follicular neoplasm that there are a bundle of lymph nodes.
Yeah.
Very unlikely. But if you find a glob of lymph nodes and they are all positive, then I think rather than bringing the patient back for second operation, you could do a total thyroidectomy as long as there has been understanding between the patient and you and the family, so that they don't get terribly surprised that, my God, we went for a lobectomy and now he did a total thyroidectomy. If that is the attitude of the patient, nothing wrong. Don't be too shy about 2 operations.
Yeah.
Right.
Wait for a sufficient amount of time. Patient will be better informed. Patient will get more confidence that he just didn't take out my thyroid for fun. I think those are some of the decisions you have to make individually. But we at Memorial always write possible total. And the possibility of changing our preclinical decision is very small.
Okay. I keep on, as I get older and I keep listening to people more and more, the point that drives home very strongly is, please keep on talking. Please keep on having a dialogue with the patient, have a dialogue with your pathologist and a dialogue with your ultrasonographer. Please keep on talking to each other. Because the more we talk to each other and the more we talk to the patient, the safer is our surgery and, of course, our own future, because no litigation. Now, this is
another thing I would like to point out.
It's a 38-year-old female, gradually every 5 years, but no sudden increase as well, no pressure symptoms. Right lobe isthmus about 5.5. Other things are normal. Investigations. This one. PSH normal. So, final histopathology is this. Now, this is a tumor which has puzzled me a few times. And now I no more worry about this. But this has happened to us. I'm sure this will happen to everybody. And I'll tell you a sad story about this. That's why I put this slide up. She is a female about to get married with 5.5 centimeter tumor. And our initial report came as malignancy, and that spread like a wildfire because people that time did not know about non-invasive follicles with papillonuclear feature. This animal was not born then, and the lady got labeled, and as our Indian scenario, problems with getting married. Lucky for us, same year, New York Times puts up a paper, that's not a cancer. And that's Sivita Bacon. So, would you have, in case with this kind of a report, everybody is comfortable saying that the treatment is over?
Yeah.
Yeah.
Absolutely. So in context of the previous case as well, you would need to understand that these are possibilities when you're dealing with large solid nodules as well. So we should counsel the patient that it could be a tumor, a neoplasm, but it could also be very benign.
Right. Now,
Dr. Madan,
this is little bit of a trick. I will not be a trick. We'll go through this. This is very straightforward.
Dr.
But the
Capre,
trouble comes
just
here.
one
That
word.
the opposite
Capre,
lobe shows
Capre,
another
Capre,
nodule,
word.
not very big, 7/5, well-defined margin, cystic, hyperechoic, so obviously benign. So does says the pathology report. One side we have got, can I go back on this? We got not so big tumor, fairly happy for a hemithyroidectomy. Opposite side says so. What will be your treatment? Will you be happy to go and just console her that the opposite nodule is benign and carry on?
How old is the patient?
35.
You know, this is one of the common problems we face. The more ultrasounds we do, the more nodules we find. Now, we have used 5 millimeter as a cutoff. Below 5 millimeter on the other side, we don't do anything because it is too small to characterize, too small to do the biopsy. Unless the radiologist strongly feels there is a calcification and it is more likely to be cancer. 7 millimeter nodule, benign needle biopsy, you can leave it alone, but patient needs to be told that there is a nodule on the other side, which we are going to monitor from the age 35 to age 95. It is quite likely at age 55, it may become 12 millimeter and we may have to operate on you because of wanting to get a better diagnosis. We could still follow with a needle biopsy, etc. And I think this is very important that patients need to know what are the implications of final pathology report on day one before we take them to the operating room. Like your two other patients, the NIFP and the follicular neoplasm, they need to be told that it is quite likely 10 days later we'll get a report of follicular carcinoma. I'm going to divide it into low risk or minimally invasive or widely invasive. If it is minimally invasive, I'll continue to monitor you for the rest of your life. If it is widely invasive, there may be some benefit or some good decision making to do completion thyroidectomy and give radioactive iodine. I think what we do in our practice is explain this to the patient before they go to the operating room. So when the final report comes, they say, oh, I know you told me this, that it may be a cancer, it is good cancer, I will leave happily. And I think that's the decision making with every patient.
So we all agreed that there is no rationale. Because two kinds of people would say, somebody would say, go ahead with total. Most of the people are happy to do a Hemi, and take home message is that institutional preferences, patient consent, and adjuvant therapy. Now, this is a case which happened to us a while ago, where total thyroidectomy, ipsilateral compartment 5 years ago. Differential thyroid cancer 2.7, largest dimension with no extrathyroid extension. That's what we thought. We thought we had done it nicely. But on regular follow-up, now he comes back with thyroglobulin of 16.2, 8 millimeter lesion in the thyroid bed, FNSC papillary carcinoma. Now I put this to Prathamesh because Prathamesh will smile. We had a similar case which Prathamesh was sent by me not so well ago, Prathamesh, with a bed tumor and a neck node with a rising TG. Daughter is a medical student. She knows all about thyroid cancer. She goes on the net. The family knows that there is 16 TG and a little sitting node there. What would you do? It's only 8 millimeter. And TG is only 16.
So you're asking about the diagnosis is already there, sir. The patient has a thyroglobulin which is raised, and you would want to consider evaluating this patient. 8 millimeter nodule in the thyroid bed would suggest that you would not miss it during surgery. And that is a concern when you're dealing with very small lesions. Even if you explore and you miss this lesion altogether, you might be in a bit of a mess. So if you have a palpable lesion and you have a rising thyroglobulin, I would consider doing surgery, but the patient has to be told that we can observe it till such time that the patient has any other lesion coming up. So I will not rush in and do a surgery. I would do an ultrasound, maybe repeat an ultrasound, see how the lesion is progressing, and then plan the treatment.
Would you not ask Professor Val's help? Would you
Yeah,
not ask him?
you will be seeing, interestingly, this patient had 3 central compartment nodes, and patient had a 2.72 tumor, and patient was not low risk to start with. It was intermediate risk, and there is bound to come back with recurrence. And whether it is a thyroid recurrence or nodal recurrence, you were expecting around 10 to 12% time. So it is better to treat this patient as an intermediate risk patient and go ahead and do the completion thyroidectomy. If you can't do, send me so I can give the iodine and ablate the patient, and patient will be disease free. The recurrence rate will be certainly low. So it is not a low risk patient. What we are talking, all the thyroid cancer is not low risk. What the practice is. This patient had a 3 node.
Has come up with a point taken to be surgically
central compartment nodes positive. 3 central compartment nodes were positive.
No. They were negative.
No, go back to the histopathology report.
I'll show you.
Okay. 2.7. Thyroglobulin 16.2. You can wait and watch, or better to go and give the radioactive iodine. This patient recurrence is not make low risk. Any recurrence doesn't make any low risk. It is immediately goes to the intermediate risk.
Yeah. What would Professor Shah do? Would you wait?
Well, that's a great
daughter
question.
is a medical student.
Okay, so I'm going to expand on this little bit. The word thyroid bed to a head and neck surgeon or thyroid surgeon is very vague. And what you need in this case is very simple. You need a CAT scan. And what we are trying to find out is what is the exact location of the disease. Yes, I agree with Prathamesh that 8 millimeter nodule you will find when you open the neck. But you want to get a little smarter before going inside. Is it at level 4, which is 1 centimeter away from the trachea, which can be observed? 99% this node has been there for last 5 years. You just didn't know about it because the thyroglobulin was not high, so you didn't. Nothing much was done. So I would strongly urge to get a CAT scan with contrast and then make a decision. Are you going to avoid operation in this patient? No. What you are trying to do is find the right time in your life and her life to do the surgery with the risk which are anticipated. And I think you showed the slide there. There is a risk about a parathyroid problem, the risk about the nerve problem, and I think patient needs to be educated on this. So, yeah, would I use the neuromonitoring? I think this is one case where it has some value, definite value. But get a cross-sectional imaging. We have really not paid much attention to the cross-sectional imaging. For a surgeon, it's a gold mine of information. If the lymph node is near the cricoid cartilage, in the cricothyroid area, you know that it is extremely close to the nerve and the risk of nerve injury is very high. That's where the patient needs to be informed that your risk of nerve injury is high, and I may consider monitoring this node for next few years to see if it from 8 millimeters becomes 12 or not. It is quite likely this nodal disease is there for last many years. And these are the judgmental calls. The next thing you need to tell the patient, I'm operating on the disease that has been seen structurally. The thyroglobulin may not come down, number 1. Number 2, there is a high risk of complications. And number 3, this operation does not prevent future recurrence, either on the same side or on the opposite side or in the superior mediastinum. Patient needs to know that. Recurrent thyroid cancer is a complex subject. And I think patient needs to be educated on this.
Correct. I agree.
Well, we went to our last case, and I'm sure Vijay will be very happy. This is a pretty straightforward case. 36-year-old male, left neck mass for 1 year, no other symptoms, left-sided nodal mass at a mid-jugular level, no movement on deglutition, FNC, metastasis from papillary thyroid CA. Ultrasonography, there are nodes from level 2 to 4, and most of them 1.5 centimeter lesion seen in the left lobe of thyroid with fine calcification. CT scan shows multiple lung nodules. I'm seeing here Professor Pal is now getting into it. He is smiling. Now, management plan. Additional investigations to whatever we have done so far. Would you like to do anything of this?
Nothing.
No brainer for the surgery.
Except what is the histology? It is follicular, it is differentiated or medullary or poorly differentiated or anaplastic. Beyond that, I don't need anything.
Papillary.
Scan, I don't need any CT scan, I don't need anything. You have to do, go ahead and do thyroidectomy, and if possible, do the lateral nodal clearance and possibly block dissection. And then lung can be taken care of by the IOD.
I think this is
very straight, non-controversial, not at all.
Yeah. So there is no alteration in surgical plan, and adjuvant treatment is known from the beginning, because these are the sort of cases we end up getting in our practice. I tried to take the cases which most of the people get in our hometown. Although there is nothing changed about the thyroid cancer in the last 100 years, so say John Charcot, and I'm sure everybody will agree on that. What is changing is our understanding and our own philosophy of treatment, either going this way or that way. We know the cross section, we are there. So I tried to remove some of the cobwebs from the minds of the guys who are listening to these debates time and again, and taken up just few cases, and also the cases which bother you because you get them in your practice, and try to get the answers from the expert, so that when you go back and have a case something like that, you know, oh, he said so. And you cannot have a god of thyroid like Professor Shah sitting here and telling you, so whatever advice you got on all this will be probably gospel truth. So I tried to do my best in the subject. So this is what I conclude.
I would like to
with.
thank Dr. Shah.
I will give back
for
to
last
Vijay Krishnan,
100
the
years,
dais,
there was a debate about total
sure
thyroidectomy.
on behalf of all the panelists.
He made it Hemi. Correct. That is the only thing. If hemithyroidectomy has really come into the books and the AT guideline, thanks to Dr. Shah.
You're too kind.
No, sir. You had really, when you are alone fighting with the last 20 years and who are in the ATA guideline, and every time you debate and there will be 10 people jumping on you saying, no, it is very under surgery. It should be treated like cancer. I have shown all those debates in ATA guideline Boston meetings, and I'm the one person who have not missed even single World Congress on thyroid cancer. I've seen how the literature has evolved over the time, and you were all the time right. You stood like a Rock of Gibraltar. Your arguments may not be
well said,
terms of evidence,
can
but
I
your arguments
get to
were
Vijay?
very rational.
Yes, sir, I'm online.
So, do we have, now we already overshot the time, but do you have any sort of a burning question somebody has sent you that I need to answer or ask the panelists?
Not specific, sir. I think most of the questions has been already discussed in detail. Can you hear, sir?
Yeah. So there's only one question which is pertinent coming from my dear friend Kundush Ahmed. No, from
so now your voice is breaking, sir.
Monitoring calcium operative.
Your voice was breaking. Can you repeat the question?
Calcium monitoring.
Yeah,
How will you do?
repeat the question. Professor Kudush from
I think the question, sir, is about monitoring serum calcium levels post total thyroidectomy. A question posted by Professor Kuddush Ahmed from Baroa.
So would you like to pass it on to the panelists?
Yeah, if Professor Shah can take it, because we have one from him, and then we'll like to know what Prathamesh does in TMH. So both of them can answer.
So what we do is, once we have done a total thyroidectomy, we like to do the calcium level that night and next day and see the trending of calcium. If the trending is upwards and the calcium is above 8.5, patient is asymptomatic, we feel very comfortable to send the patient home. Luckily, at some of the biochemistry labs in the United States, we can get the parathormone level with calcium, which is quite helpful to judge. If the parathormone is about 12, 13, you feel comfortable to send the patient home. But that doesn't make a decision. It's the symptoms of the patient and the calcium level. Most of the patients, post-operatively, they go home with some calcium. 6 tablets of Tums or calcium carbonate, whatever you like to do. And only because, not because they're going to get symptomatic, but I don't have to worry about them till they come back for follow-up in a week when I can check the calcium. So that's our general policy. Send the patients home with some calcium. We have also started, because we are in New York where sun is very little, the vitamin D levels of almost all New Yorkers is very low. So we check the vitamin D now pre-operatively and try to optimize it to bring it to 30. So those are our approaches. A calcium level and trending of the calcium level for 24 to 48 hours. Now, a lot of surgeons send the patient home that night or soon after surgery, 4 hours after surgery. They send the patients universally with calcium and vitamin D or calcitriol. I think before Prathamesh comes, I think Neil is world expert on this subject, and I think he gave a fantastic talk last time. So before, I think Prathamesh has expertise from Tata, but let's see what Neil says.
Yeah, thank you, Ashok. I was also going to reiterate the importance of vitamin D loading before total thyroidectomy. It's very, very important because it certainly mitigates any prolonged stay of the patient following total thyroidectomy. We're fortunate in that we are able to measure the parathyroid hormone and the calcium together on the evening and the morning. We routinely give patients 1 gram of calcium or calcium on the evening after surgery and 1 gram the following morning. And again, you're looking at a trend. If the PTH is above 1, then we don't have any problems. But we do send the patients home on some calcium on a PRN as required basis. So that's important. If you do not have the ability to measure parathyroid hormone, and if they're vitamin D replete, and this is very important because it doesn't work if they're vitamin D deficient, look at the phosphate, because the phosphate or a rising phosphate is very specific for an indication as to whether they've got pending parathyroid problems. So if they're getting a high phosphate with a low calcium, it really means that the parathyroids are not working particularly well. And it's probably a reasonable paradigm to actually give them, vitamin D and calcium on discharge. Important to give them vitamin D because they won't absorb the calcium without the vitamin D as well.
Thank you, Neil, very much. I was going to come to him the last because I knew that Neil has got a lot of thoughts and Neil has got experience of both. Working in a place where there is no post-op estimation of calcium or PTH from another source. So I was going to come to that balance. But Neil, well said, and we all follow that regime. But Prathamesh, what's the protocol at Tata?
So it's similar to what Dr. Shah mentioned. After 48 hours, we will do the calcium and then monitor the patient. A corrected calcium less than 8, we would obviously look at a biochemical hypocalcemia and then consider giving calcium supplementation. Most of our patients are vitamin D deficient, so we would give calcium along with vitamin D. And these patients, if they are having less than 8, we would then consider replacing them appropriately with calcium supplementation, and we would send them home with calcium supplementation. And then at the first follow-up, they would be monitored. The calcium would be monitored again along with the pathology reports. And then we would then consider whether we want to continue the calcium supplementation or we would like to then stop. We do not routinely do parathormone testing because it is expensive. And of course, in the patients whom we would then require to do parathormone levels, if they're consistently showing low calcium levels in spite of your supplementation. So that's
Thank you very much. Yeah. You know, something very pleasing, that the questions which have come, and that's credit to the Indian Society of Thyroid Surgeons. I mean, I'm very happy about it. Nobody is asking about recurrent nerve. I think that is graduating. See, when you graduate in thyroid surgery over the years, recurrent nerve becomes no-brainer. Calcium, and I'm so happy that all the 4 questions that came up here on my screen are related to post-operative calcium, because I'm sure everybody loves. Yeah, go on, Professor Bal.
Dr. Bal, you are muted.
Okay. All the people who are involved in thyroid cancer management, I would like to point here that in thyroid cancer, we would like to keep the calcium around 8 to 8.5, not the 9.5 to 10.5, because these people are more prone for formation of stone formation. So you have to keep in thyroid cancer, if there is total thyroidectomy done, and you have to keep the calcium lower side, not higher side.
Is there any way to
suggesting they try to keep it around to 10, 9.5 to 10, which is wrong. Very carefully, if you analyze, if you keep this patient, they are low threshold, and you have to keep the calcium around 8 to 8.5, not 9 to 10.
Yeah, point taken.
It's basically endorsing what I said about the issues of permanent hypoparathyroidism, that you know, surgeons, we're not particularly good at managing it, I have to say.
Yeah, I know. They try to give pump lots of calcium, I know.
So they get hypercalciuria and nephrocalcinosis. Yeah. And then many years later, they're in chronic renal failure and in the transplant. Of course, we don't see the effects of what we've done to these patients, you know.
Yeah.
So
I have seen patient comes with the seizure.
Not a complication. And I think it's very difficult, is it not, for us to decide whether the parathyroids are perfect after a total thyroidectomy. You can have really difficult operations and you think that, oh, this patient is going to have terrible problems, and then nothing. And then you feel that you've done a model thyroidectomy and they become hypocalcemic, particularly the Graves patients, because they've got hungry bone disease. So, you know, it is a really a real big problem, and I think it's something we could do better. I think we need technology, you know, some form of technology to enhance our understanding of parathyroid viability after total thyroidectomy. I think there's only so far that surgical technique is going to take us to actually get our complications down to 0%, which is what we want to aspire to.
Neil, can I, Vijay, just last one question, because what Neil has opened up into an area could be another 2 hours discussion, is about sort of monitoring or identifying parathyroids intraoperatively. I mean, Prathamesh is smiling because they do it there. They've got a fancy gadgets in Tata now where they can sort of shine rays and colors and give indocyanine. I think, Prathamesh, just in few lines, is it working? Is it worth it?
It's not really foolproof. We are using indocyanine green and flow optics technology, but I wouldn't say that it is foolproof, especially when you have a whole load of lymph nodes around the parathyroid. I'm not sure it will really help us. But it's a technology in evolution, and I'm sure that in time to come, we will get this perfect. near-infrared technology is here to stay, and I'm sure in time to come, it will become more feasible for us to actually identify the parathyroids better.
I don't think we need technology necessary to permit us to identify the parathyroids. We need technology to tell us about their viability.
Right.
At the end of
including the viability of the parathyroids.
And I think we should be able to identify the parathyroids, maybe not all of them, but the vast majority of them in the total.
I think we should have a very low threshold for re-implanting any parathyroid which doesn't look very happy. Rather than leaving it there and doing the test like cut the thing, that hematoma release technique. If you are in doubtful, they look any other color but what they should look like, and you are sure that that's parathyroid, I would implant. I will have very low threshold for doing it because I am worrying about.
That's another conference, madam, because even auto transplantation is controversial.
Yeah, but I quite agree that this could be another 2-hour session. But Vijay, thank you very much. On behalf of all the participants, panelists, delegates, I profoundly appreciate the gesture of Indian Academy of Otolaryngologists. Vijay, you are too good. Sarath, thank you very much. And I don't see KK here, but I'm sure KK and Mohan must be somewhere around. Mohan is a very dear friend and we both respect each other very much. So thank you on behalf of all of us. I enjoyed it thoroughly. Thank you all very much. You are a great source of knowledge and you're a great source of encouragement. Thank you very much, Professor Shah, Neil, Prathamesh, Jyoti, everybody.
Thank you so much,
Professor Bal. Today we didn't have much of firework, but maybe next time we'll have some cases where there will be firework coming from you. Niti and Abhishek, thank you very much.
Happy New Year,
everybody.
Okay. Bye-bye.
Thank you, Dr. Turley. Bye.
You want to take over and thank Sipla people?
Yeah, Dr. Sarath, I would like to. Sarath?
Sarath, you're muted.
Sorry, sir. It was indeed a very interesting and informative session. We thoroughly enjoyed it, and I would like to personally thank Professor Ashok Chaha, Professor Madan Kapre sir, Professor Prathamesh Pai sir, Professor Neil Tolley, Professor C.S. Bal sir, and Dr. Niti Kapre, and Dr. Abhishek Vaidya, and Professor Jyoti Dabulkar, ma'am. It was, as a young surgeon, it had opened up a lot of ideas, a lot of things which we had, had doubts about, and we have made it clear, and it was to the point. And I would like to thank Sipla for supporting us, and hopefully this will gain more encouragement for us to have many more sessions like this. And as next week we have a salivary gland session, and the viewers will surely be part of it and make use of it. And thank you so much, and thank you Vijay Krishnan sir for this opportunity. Thank you.
Thank you, Ananda. With this we conclude the session. Thank you.
Thank you.
Bye.
Goodbye.
Good night and God bless.